Services and Subcommittee on Health, Employment, Labor, and Pensions will come to order. Welcome, everyone. I note that a quorum is present. The subcommittees are meeting today for a joint hearing to hear testimony on how to save a life, successful models for protecting communities from COVID-19. This is an entirely remote hearing, and as such, the committee's hearing room is officially closed. All microphones will be kept muted as a general rule to avoid unnecessary background noise. Members and witnesses will be responsible for unmuting themselves when they are recognized to speak or when they wish to seek recognition. If a member or witness experiences technical difficulties during the hearing, please stay connected on the platform. Make sure you are muted and use your phone to immediately call the committee's IT director, whose number was provided in advance. Should the chair experience technical difficulty or need to step away, Chairman DeSaulnier or another majority member is hereby authorized to assume the gavel in the chair's absence. To adhere to the committee's 5-minute rule, staff will be keeping track of time using the committee's digital timer, which appears in its own thumbnail picture. Members and witnesses are asked to wrap up promptly when their time has expired. Pursuant to Committee Rule 8C, opening statements are limited to the chairs and ranking members. This allows us to hear from our witnesses sooner and provides all members with adequate time to ask questions. I now recognize myself for the purpose of making an opening statement. Good morning, everyone. Today we're examining best practices for increasing COVID-19 vaccinations through the lens of health equity. To date, the CDC reports that 639 people, I'm going to say that again, 686,639 people in the United States have tragically died from COVID-19. We are now experiencing a resurgence of the virus as the Delta variant continues to spread across the country. Every day we continue to lose an average of more than 2,000 of our loved ones, friends, and neighbors. Unfortunately, millions of unvaccinated Americans are still at risk of succumbing to this deadly virus. Vaccination rates have been lowest in the most underserved areas, particularly rural and BIPOC, Black, Indigenous, and people of color communities. And for a multitude of reasons that our expert witnesses will discuss, many unprotected Americans are simply not getting the vaccinations they need to stay safe and healthy. These individuals are not concentrated in any single region of the country or on any one end of the political spectrum, so we as policymakers should be working together to better support our public health professionals in reaching those populations. To address obstacles to vaccination, the American Rescue Plan Act invested more than $240 million in community-led efforts and provided significant funding to increase vaccination rates in rural areas. These investments help bolster the efforts of a wide range of community-based organizations and federally funded partners, such as the Aging Network, supported by the Older Americans Act, and the Community Action Network, authorized by the Community Services Block Grant. These efforts have been essential to saving lives of those who have long been medically underserved. For example, many community action agencies across the country have supported vaccinations by engaging in outreach and education, providing vaccine registration, scheduling assistance and transportation, and hosting vaccination clinics or supporting, importantly, mobile units. To highlight the successful approaches of these entities, I ask unanimous consent to enter into the record a report from the National Community Action Foundation entitled Community Action and Health Equity in Response to COVID-19. Without objection, so ordered in the record. Today's hearing is an opportunity to learn from successful initiatives so we can provide every community with the tools they need to finally defeat this virus. If we listen to the advice of our medical experts and work together, we can keep our communities healthier and save lives. So thank you again for your witnesses for being here today. I now yield to the distinguished ranking member, Mrs. Sparks, for her opening statement. She will be serving as ranking member of the Subcommittee on Civil Rights and Human Services for this hearing. I turn it over to you, Mrs. Sparks.
Thank you, Madam Chairman. I believe it's an important discussion to have. How do we manage and mitigate pandemic risks, look at them comprehensively, and stop politicizing serious government decisions to play politics with people's lives or advance a party agenda. Let's look at the prior year's successes. Operation Warp Speed was the gold standard of vaccine development and distribution. Under President Trump, who promptly cut red tape and regulations, our private healthcare sector was able to produce several life-saving vaccines in record time. This proved, yet again, that America's healthcare system thrives when government gets out of the way and supports private innovation. As we continue discussing successful models for protecting communities from COVID-19, we must acknowledge that the most effective mitigation and prevention strategy, vaccination, is both free and widely available for every American over age 12. Our free enterprise system and the private healthcare industry made this miraculous feat possible. The timing of the pandemic to happen during an intense election year caused it to be politicized even further. And despite claiming to be the party of science, Democrats fueled the public's vaccine hesitancy by sprawling doubt over whether a Republican president could be trusted to deliver safe and effective COVID-19 vaccination. This politically motivated disinformation was cowardly, cost people their lives, and exacerbated health disparities. Unfortunately, the Biden administration continues to sow fear, doubt, and confusion. Through ever-changing guidance and policies crafted along ideological lines, President Biden has created another pandemic, misinformation. We need our commander-in-chief to put facts before factions and to clearly communicate with the public about the state of COVID-19, the vaccine's effectiveness, and the path forward to a pre-pandemic level. From the latest vaccine mandates, which are not based on risk or science, to precluding our children from in-person learning, which is not based on risk or science, this president has traded our country's long-term viability for short-term political wins for the Democrat Party. To capitalize on early successes we experience responding to COVID-19, it's imperative that we reestablish local and state control, working together with those leaders to execute policies that encourage vaccination and government transparency. Not government force and fear. It backfires and only belongs to totalitarian regimes, not a constitutional republic of free people. Only then can we begin to regain our pre-pandemic prosperity. Thank you to all witnesses for joining us in what I hope, for a change, will be a fact-based, productive, and meaningful discussion. And I yield back.
Thank you, Ranking Member Spartz. And now I recognize the distinguished chair of the Subcommittee on Health, Employment, Labor, and Pensions, Chairman DeSaulnier, for the purpose of making an opening statement.
Thank you, Chair Bonamici. Thank you so much for this hearing. And thank you to all of our witnesses. Really terrific for your words here and for your work. The Delta variant is continuing to pose a serious threat to our public health as we mourn the loss of more than 680,000 family members, friends, neighbors, and fellow countrymen so far. This is particularly true for communities that have historically been left behind by our healthcare system and suffered the greatest losses during this pandemic. Despite these significant challenges, hope is far from lost. COVID-19 vaccinations continue to be our most effective strategy to prevent people from succumbing to this virus. And the critical investments we provided in the American Rescue Plan are helping to expand vaccinations in the areas that need them most. Yet even as we fight against the Delta variant, we are still seeing lawmakers and leaders politicize vaccinations instead of following the science and putting the health of our communities first. This is a disservice to the American people that we all represent. We have a responsibility to unite behind this scientifically proven vaccine and public health guidance that are saving lives as we speak. In the area I am very privileged to represent, the San Francisco Bay Area, Contra Costa County, we've been working to make significant investments in vaccine equity. In May, the equity gap between white residents in my county and African American residents was 22%. By August, thanks to the hard work of people in our public health system, by August, however, that equity gap had decreased from 22% to 6%, 22% to 6%. To achieve these significant improvements, the Contra Costa Regional Medical Center recognized the public hospital that they had to do more than just set up vaccine sites in neighborhoods with low vaccination rates. They created a system with preferential scheduling in those neighborhoods where residents in zip codes with the worst health outcomes were given the first appointments. They also created a multilingual call center to schedule appointments for residents and conducted outreach through text campaigns and direct phone calls to residents in those communities. By coupling our equity lens with data and technology systems, Contra Costa County was able to prioritize residents and address the equity gap in a significant way in a short period of time. Today, I look forward to hearing from our witnesses about what we should do in best practices, what we should do from lessons they have learned in their critical efforts to help underserved communities recover from this historic pandemic, and then make sure that all Americans benefit. I'm now happy to recognize my friend, the ranking member, Mr. Allen.
Mr. Allen, you're recognized for 5 minutes for your opening statement.
There we go. All right. Can you hear me okay?
We can hear you.
Mr. Okay. Thank you, Mr. Chairman and Madam Chairman. As I look back, our nation's pre-pandemic economy was the best in the world. Unemployment, particularly for minority groups, was an all-time low. Wages increased far more than 19 straight months and grew faster for the bottom 10% of income earners than it did for the top 10% of income earners. Business owners and workers are eager to get back to this unprecedented period of economic growth and prosperity. But President Biden is either incapable of or unwilling to lead our economy and our nation forward. There are currently over 8.4 million unemployed Americans and 10.9 million job openings, a gap that is due in part to the Biden administration's absurd policies that are keeping would-be workers out of the workforce. For minority groups, the unemployment rate is as high as 8.8%. At gas pumps and grocery stores, workers are spending more due to President Biden's inflation crisis. To put it simply, inflation is a tax on the middle class, and the Biden administration is forcing already cash-strapped families to tighten their belts to pay for Democrats' outlandish taxpayer-funded spending sprees. It is truly astonishing to watch an administration trade long-term economic prosperity for short-term liberal special interest. The worst part is that there is little evidence that government-mandated lockdowns did much to reduce COVID-19 transmissions. As we've successfully demonstrated in my home state of Georgia, our economy can and should safely reopen. Effective life-saving vaccines are readily available to those who make an informed decision based on their physician's advice. Schools and employers have received far more government funding than necessary to weather the pandemic-induced economic disruption. More top-down mandates from Washington will not alleviate the financial suffering this president's policies have inflicted on this nation. As members of Congress, we must lead by example. It is imperative that this committee meet in person as a signal to job creators that it is safe for them to do so as well. Without strong leadership from our president, it is equally as important that we continue to bolster state and local efforts to balance public health with economic prosperity and uphold individual freedoms. The federal government does not have all the answers, which is why I look forward to a discussion with our witnesses about how our economy can regain its footing without burdening business owners and restricting individual freedoms. And with that, I yield back.
Thank you very much, Ranking Member Allen. And now I will introduce our witnesses. Dr. Lena Wen is a professor and distinguished fellow at the Fitzhugh Mullen Institute for Health Workforce Equity at the George Washington University Milken Institute School of Public Health in Washington, D.C. Welcome, Dr. Wen. Dr. Viviana Martinez-Bianchi is the Director of Health Equity and is an Associate Professor for the Department of Family Medicine and Community Health at Duke University School of Medicine in Durham, North Carolina. Welcome, Dr. Martinez-Bianchi. Mr. Ovik Roy is the President of the Foundation for Research on Equal Opportunity in Washington, D.C. Welcome, Mr. Roy. And Dr. Chris Purnell is the Chief Strategic Integration and Health Equity Officer at University Hospital in Newark, New Jersey. Welcome, Dr. Purnell. We appreciate the witnesses for participating today, and we look forward to your testimony. Please note that your written statement will appear in full in the hearing record, and you are asked to limit your oral presentation to a 5-minute summary. And after your presentations, we will move to member questions. I know the witnesses are aware of their responsibility to provide accurate information to this joint subcommittee, and therefore we will proceed with their testimony. I will first recognize Dr. Wen for 5 minutes for your testimony.
Thank you very much, Chairman Bonamici, Chairman DeSaulnier, Ranking Members Sparks and Allen, and Chairman Scott, Ranking Member Fox, and the distinguished members of the subcommittees on Civil Rights and Human Services and Health, Education, Labor, and Pensions. Thank you for convening this important conversation to address the urgent actions that must be taken to protect our communities. There's no question that COVID-19 has unveiled rampant health disparities, and that people of color, families with low income, who already bear the brunt of disparities, have suffered the most. We must go beyond admiring the problem. And in my testimony, I want to emphasize 6 actions that Congress must take to reduce the disproportionate impact of the pandemic on vulnerable communities. Number 1, take every available measure to protect our children. Now is the most dangerous time in the pandemic when it comes to kids too young to be vaccinated. The CDC has provided extensive evidence-based guidance for what should be done in schools. Congress should stand behind the CDC's recommendations to keep schools open safely. Number 2, increase availability of rapid testing. Testing is a crucial layer of protection that the US has not utilized to its full potential. Imagine if every student can take a rapid test before going to school, and every worker can test before going to work, and if extended families can all take tests before seeing one another. A rapid antigen test is not 100% effective, but even if it's 80% effective, it will identify 80% of those who otherwise could have infected others. The UK has made free tests available to everyone so that all residents can be tested twice a week. Canada is providing free rapid tests to businesses. The Biden administration has said that they will purchase 280 million tests for around $7 each, but this is far too little for far too much. Congress should urge the administration to make free tests available for everyone so that all Americans can be tested at least twice a week. Number 3, improve vaccination rates. Only about 55% of Americans are fully vaccinated, which is far too low to stem the surge of coronavirus. It is unacceptable that about 2,000 Americans are still dying every day. Members of Congress should use your extensive platforms to support all efforts to increase vaccine uptake, including scaling up education and outreach, combating misinformation and disinformation, and increasing accessibility of vaccines. Baltimore is among the cities that utilized mobile vaccine vans that travel to people's homes. This was particularly necessary for older residents, homebound individuals, people with disabilities, and others whose barrier to vaccination is mainly about access. New York City is also a standout in making vaccines available in transportation hubs and in schools. These efforts to reach people where they are continues to be so important because nearly half of the unvaccinated are in the unvaccinated but willing category. They can be reached through ongoing outreach, and vaccine requirements will help as well. Number 4, ensure workplace protections. Congress should urge the administration to make high-quality N95 and KN95 masks available to every worker free of charge. While COVID-19 cases are surging, indoor masking should be required at workplaces unless there is universal vaccination and a robust testing regimen. Number 5, increase data collection and improve oversight. There should be a real-time dashboard coordinated by the federal government with data uploaded by state and local health departments that provide on-the-ground information about primary vaccinations, booster uptake, breakthrough infections, testing rates, among other metrics. This provides transparency and accountability and allows for targeted interventions. Federal funding can be tied to the availability of these data, adding a strong incentive for compliance. And number 6, support safety net public health systems. It's excellent that there's new funding to address COVID-19, but we must not forget that public health is not only about infection control. There were other issues that were crises prior to COVID and have gotten worse, like the opioid epidemic, the crisis of maternal health, the lack of food and housing access. Congress should allocate resources to address these other public health issues too, and Congress should also allow maximal flexibility for local jurisdictions that are closest to the ground and that can best serve their communities. Thank you for considering these 6 specific steps to combat COVID-19, reduce disparities, and in so doing, improve health for all and strengthen our communities.
Thank you very much for your testimony, Dr. Wen. Next, we're going to hear from Dr. Martinez Bianchi. You're recognized for 5 minutes for your testimony.
Thanks, Chairwoman Bonamici and Chairman Desaulniers, ranking members and members of the subcommittees for inviting my testimony. I offer this testimony in my personal capacity and as a representative of Latin 19. My views do not necessarily represent the views of my employer, Duke University. I am pleased to be here today, not only as someone who has been on the front lines of the COVID-19 pandemic as a family doctor, but also on the front lines in our Latinx community as co-founder of Latin 19, the Latinx advocacy team and interdisciplinary network for COVID-19. Latin 19 is a multi-sector coalition, including over 700 people, representing a broad range of organizations and the Hispanic community across Durham and in North Carolina. Latin 19 was launched in March 2020 in anticipation of the expected impact of COVID-19, and it has been meeting every Wednesday at noon via Zoom with simultaneous interpretation. We provide a critical shared space for members of the Comunidad Latina, multi-sector leaders and allies to create collaborative and interdisciplinary solutions in a trusting and committed environment. At our weekly meetings, attendees discuss challenges, needs, and opportunities facing the Latina community and propose changes in programs, systems, and policies for the improvement of health and the promotion of health equity. Latin 19 meetings consider the myriad of social and health conditions that are driving the increased risk and disproportionate burden of COVID-19 among the Latinx community. For example, Latinx employees are overrepresented in frontline essential jobs. They're more likely to live in densely populated areas and in multi-generational, multi-family households. Another key reason has been the systematic exclusion from access to health services, health information networks, and health insurance, even when eligible. It is ironic, disappointing, and unacceptable that the Hispanic community lacks access to health care, given their significant contributions to the labor force and to the economy of the country. Throughout 2020 and 2021, Latin 19 has engaged in broad dissemination of information on COVID-19 prevention and services by developing and sharing culturally appropriate, essential information in Spanish and English to multiple networks, including local and national news outlets. In addition, the electronic patient portal of Duke Medical Center is being made available in Spanish to facilitate connection with the health system. In July 2020, Hispanics comprised almost half of the COVID-19 cases in the entire state of North Carolina, while they were only 10% of the state's population. Since July 2020, Latin 19 has been at the forefront of COVID-19 testing, and since January, we have been involved in vaccination efforts to reach the Latinx communities. These efforts have contributed to lowering COVID-19 case rates and an increase in COVID-19 vaccination. Currently, the proportion of Hispanic residents vaccinated in Durham County is the same as non-Hispanic residents, and we have reached another important milestone. At 59%, the proportion of vaccinated Hispanic residents in Durham County is now higher than the proportion of all people vaccinated for the whole state. As other entities might be considering a Latin 19 type model, I recommend these best practices. Number one, building trust is vital, but it can take time, and it takes being a presence, being a member of the community, being curious, listening to the questions and the diversity of voices, exhibiting our own humility and vulnerability when we're trying to come to solutions together with community members. Number two, build and maintain strong channels of communication with leaders in government, public and private health systems, and the business sector to translate current needs, missed opportunities, and successes for the Latinx community. Number three, connect, communicate, and empower. As part of Latin 19, we have learned that how and from whom people get their information is key. Number four, direct community care, including mobile primary health care to address community needs and diminish barriers to access. Community health workers or promotoras are integral to the successful deployment of healthcare in the community. Number five, engage the Latinx community to participate and have a voice in clinical and community-based research. And number six, education. By providing learners the opportunity to engage in community-based experiences and work closely with educators and leaders in advocacy, healthcare disparities, and in the intersection between primary care and public health, Latin 19 impacts the training of the next generation of healthcare professionals and the recruitment of a diverse workforce representative of the communities we serve. Si se puede if we engage our community. I want to thank you for this opportunity to offer testimony on this critical issue. The Latin 19 Network and I stand ready to be a resource for the subcommittee's efforts, and I will be glad to provide any additional detail, data, and recommendations at your request.
Thank you for your testimony, Dr. Martinez-Bianche. And next, we're going to recognize Mr. Roy for 5 minutes for your testimony.
Chairs Bonamici and DeSaulnier, Ms. Sparks, Mr. Allen, members of the subcommittees, it's good to see many of you again. Thanks for inviting me here today. The Foundation for Research on Equal Opportunity, or FREOP for short, is a nonpartisan think tank that focuses exclusively on ideas that can help improve the lives of Americans on the bottom half of the economic ladder. I welcome the opportunity to discuss how we can do better to protect communities from COVID-19. A year ago in The New Yorker, Alec McGillis wrote about a 12-year-old from East Baltimore named Shamar. Despite a difficult home life with a mother who suffered from drug addiction, Shamar had a special talent for math and loved school. But Shamar's school didn't love him back. Contrary to all evidence regarding low transmission and risk of the coronavirus in young children, Maryland kept its schools closed. McGillis saw the enthusiasm for education evaporate from Shamar as his education was replaced by Zoom links that didn't work for classes taught by teachers who didn't show up. Those who endorsed the closure of schools have argued that it was worth it in order to save lives from COVID-19. But we didn't save lives by shutting down schools. We diminished them. How many permanent dropouts have we created with COVID-related school closures? On average, Americans without a high school diploma live 10 to 13 years shorter than those with a college degree. COVID-related school closures have disproportionately affected lower income and minority students. By last summer, 2/3 of white fourth graders were enjoying fully in-person schools compared to only 45% of Hispanic, 41% of Black, and 27% of Asians. As we at FREOP detailed last summer, nearly all European countries kept their schools opened in 2020 and suffered no greater risk of COVID transmission or illness as a result. Here in America, those places that have reopened schools have seen similar outcomes. Too often, the federal and state governments have acted as if all Americans are at equal risk of illness and death from COVID-19, when from the very beginning, it was clear that the elderly were at far more at risk than young children. On April 17th, 2020, 78% of US COVID deaths were in individuals older than 65. Today, it's 77%. By contrast, only 389 Americans under the age of 15 have died of COVID, fewer than the number of deaths from influenza in an average year. We were not nearly aggressive enough last year in protecting elderly Americans from COVID, especially those who live in nursing homes and assisted living facilities. In 2020, nearly 40% of all US deaths from COVID took place in long-term care facilities housing 0.6% of the US population. And yet, as late as last June, 11 states weren't bothering to track how many of their deaths were taking place in nursing homes. Infamously, New York, New Jersey, Michigan, and other states forced nursing homes to accept elderly individuals being discharged from hospitals with active SARS-CoV-2 infections, contributing to the spread and lethality of the virus. Notably, nursing home residents are disproportionately low-income recipients of Medicaid. Now that we know mRNA vaccines work, it is important to approve their use in children aged 5 to 12 and accelerate development and authorization of new vaccines that can further protect against variants of concern. The FDA needs to get out of the mentality of treating COVID vaccines like cholesterol drugs. We're in a public health emergency, and authorization of new vaccines should take that into account, especially for mRNA vaccines, which can be rapidly adapted to novel variants. Moderna's first vaccine was designed in January of 2020, 2 days after the SARS-CoV-2 sequence had been published by a Chinese scientist. Now that we know that these vaccines work, we shouldn't have to wait 11 months for the next generation. As I discuss in my written testimony, I have concerns about OSHA's employer vaccine mandate, but the Biden administration is right to require that nursing home staffers receive the vaccine unless they have a medical reason not to. Infected staffers play a significant role in spreading the virus among nursing homes in 2020, and we must avoid a repeat of this problem in 2021. The problem is, federal agencies and many local governments continue to act as if everyone is at the same risk of dying of COVID-19, for example, by recommending or requiring that young school children wear masks despite their limited benefit in that setting, since children are at very low risk and teachers can receive the vaccine. Of the 180 million Americans fully vaccinated, only 19,136 have been hospitalized, a rate of 0.01%. Of those, 86% of deaths and 69% of non-fatal hospitalizations have occurred in people over the age of 65. When governments act as if everyone is at equal risk of illness or death from COVID, irrespective of vaccination status, previous infection, or age, it can be no wonder that hesitant Americans see little benefit in receiving the vaccine. If we want to overcome that hesitation, we have to act like vaccines save lives, which they absolutely do. Thank you.
Thank you for your testimony. And finally, we're going to hear from Dr. Purnell. Dr. Purnell, you're recognized for 5 minutes for your testimony.
Thank you, Chairwoman Bonamici, Chairman DeSaulnier, Ranking Members Sparks and Allen, and members of the subcommittee for the opportunity to share my institution's approach to health equity and our experiences during the COVID-19 crisis. My name is Dr. Chris T. Purnell, Chief Strategic Integration and Health Equity Officer at University Hospital in Newark, New Jersey. I am the daughter of Timothy L. Purnell Sr., who lost his life to COVID on April 13th, 2020. On the day U.S. Army reservists arrived to help us save lives, my father died in another hospital 4 miles away. A brave man who overcame the Jim Crow South and worked at the famous Bell Labs. He couldn't survive this pandemic. I am the sister of Kim Maria, a breast cancer survivor, and now a long COVID survivor too. I also invoke the lives of 2 cousins and 13 university hospital heroes who passed from this virus. While COVID's toll on all Americans is seismic, the collision of systemic racism and COVID-19 has led to earthquakes of devastation in Black and Brown communities like ours, where my hospital provides critical care as the state's public hospital, a level 1 trauma center, and a principal teaching hospital for the Rutgers Biomedical and Health Sciences. In New Jersey, there have been nearly 1 million confirmed cases, leading to more than 27,000 deaths. Newark, the most populous city, has felt COVID's brutal grip with over 40,000 cases and 1,052 deaths. It's known that racism unfairly disadvantages some individuals and groups, unfairly advantages other individuals and groups, and saps the strength of the whole society. Albeit racism operates as a pre-existing American condition. Drivers of COVID mortality in Black and Brown populations likely include increased COVID exposure due to poverty, residential crowding, frontline occupation, and public transportation, higher rates of known comorbidity not effectively treated, and a higher burden of unrecognized disease from the lack of access to or trust in care. To solve disparities, we must enact an anti-racism agenda in healthcare and society more broadly. Health equity must be central to care, and the integration of clinical medicine and public health must be seen as key to preparedness. The first priority: strengthen primary care through community health centers, community health workers, and fully funded safety net institutions, and expand insurance coverage in order to provide robust access to care for all. As a safety net, University Hospital re-engaged persons lost to care during the pandemic and connected them to primary care and prevention, administered more than 47,000 vaccine doses, coordinated the state's vaccination bans, providing 2,840 shots to 10 low-income, low-vaccinated communities across 76 days, and is building a prevention army. The second priority: healthcare must deliver high-quality care and practice accountability from a historical, authentic, and transparent place to build trust. It matters who the providers are, which trusted messengers are amplified, and how we share power to ensure socially and culturally fluent and competent care systems. University Hospital developed a multi-format, multilingual engagement strategy, completed its first 360 cultural competency assessment, mobilized the Community Advisory Council, and collaborated with city stakeholders to perform the most robust community health needs assessment in our history. Third priority: deploy a social determinants of health strategy to tackle differences in exposures and life opportunities. For instance, UH is incentivizing our suppliers to drive economic empowerment among local and regional and minority and women-owned businesses. Our partners at the state have made policy decisions through a health equity lens. Beyond their 1,500 vaccination sites, the state has mandated reporting of race and ethnicity data, activated a COVID community core, and created a vulnerable populations plan. Finding ourselves in the eye of the storm, no one in our community has been spared. Yet with programs designed to share and process our collective grief and trauma, we battle both pandemics alongside all those impacted in the human circle and vow to save lives by all means necessary. I thank you for this opportunity to share.
Dr. Purnell, thank you for sharing your expertise, but also for sharing your personal story. And I know everyone here shares condolences on your personal loss of your father and family members. Now we're going to move on to questions, but before we do that, I wanted to add on the written statements, without objection, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. on October 11th, 2021. So now under Committee Rule 9A, we will question the witnesses under the 5-minute rule. As this is a joint subcommittee hearing, after the chairs and ranking members, I'll be recognizing subcommittee members based on seniority order on the full committee. Wait for the bells to stop here for just a minute. As chair, I now recognize myself for 5 minutes. So thank you again to the witnesses for your testimony. You've highlighted some good examples of where you had success in overcoming the many obstacles that health professionals and community groups face in their efforts to help people get vaccinated and win the fight against COVID-19. So in the district I'm proud to represent in Northwest Oregon, Washington County, Oregon recently became the first county in the state to cross the threshold of vaccinating 80% of adults. And also in Oregon, the Oregon Pacific Islander Coalition has been working successfully with state and local partners to vaccinate more than 90% of Oregonians who identify as Native Hawaiian or Pacific Islander. They are meeting people where they are, such as a local food market or favorite neighborhood restaurant. They often pair this outreach with additional support, maybe a meal or fresh produce or groceries that can be used to make culturally traditional recipes. And these sites, importantly, are run by trusted community groups, staffed by people who speak the same language as community members, and held in familiar locations where people feel comfortable and safe. And it's made a difference. So I'm going to start with Dr. Martinez-Bianchi. As we approach the end of the second year of the pandemic, what are the most effective ways to build community trust And how can local providers continue strengthening their engagement with underserved communities to address language barriers and provide culturally appropriate healthcare and services?
In our experience, the most important way of building that trust is being a presence, listening, like I said before, being humble in our approach. When we work together, when we are listening to our community, what we saw at the very beginning of the pandemic, it was that because there were no health networks, there was not enough information, the community had started doing it themselves. They were addressing food insecurity, they were canvassing their own neighborhoods, trying to understand how much of an impact COVID-19 was having in the community. So we got together with the community to understand the impact of what was happening. We started seeing the numbers before there were numbers on the CDC or in the state tracking, right? Connecting, being there, and also making sure that we are, as health professionals and academic institutions, that we understand that the community knows where the problems are occurring. The community knows what are their barriers, and they actually have wonderful ideas on how to diminish and improve access. So
that's wonderful. I don't mean to cut you off, but I want to get another question in before my time runs out. Thank you. Dr. Wen, you mentioned this in your testimony. According to recent data from Kaiser Family Foundation, about 25% of unvaccinated adults do plan to get a vaccine by the end of the year. But conflicting medical opinions and accurate information, especially on the internet, related to COVID-19 have created some serious challenges to reaching population immunity through vaccination. So when communicating with people who are ambivalent or skeptical, what effective strategies have healthcare providers and public health educators used to increase uptake, address concerns, and also debunk misinformation?
I really appreciate the question because I do think we need to recognize that there are a lot of people who actually are in that middle ground. There are definitely some people who are really dug in and will not get the vaccine. There are other people who are who are strong proponents of the vaccine, but there are a lot of people who need a little bit more of a push. And so everything that was said earlier about the trusted messenger, reaching people that where they are, all those are very important. But to your question, I think it's really important to approach people individually with compassion, not with judgment, to understand why it is that they have not yet gotten vaccinated. Many people are not trying to be purveyors of misinformation or disinformation, but they may have heard something. And actually that disinformation is harming their health. It's preventing them from protecting their families in the way that they should. I also do think that vaccine requirements, including in the workplace, can also push people to get vaccinated. United Airlines, for example, after instituting their vaccine requirements, already is at 97% compliance. And I think that in combination with a robust education campaign is essential.
Thank you. That's important. And my final time, Dr. Wen, again, I'm really concerned about seniors over the age of 65 who may be eligible for a booster or are eligible for a booster if they had Pfizer. So what systems need to be in place to effectively deliver those booster shots to seniors who are outside of a long-term care setting where they may have somebody come in to provide them, but seniors outside of the long-term care system?
I think
3 seconds left.
Things are a lot better now than they were at the very beginning of the vaccination campaign. Seniors should be able to get vaccines in their pharmacies, in their grocery stores, in their doctor's offices. Those community vaccination sites are absolutely essential. And I think we also need to do even more outreach to bring vaccines to where people are, including in churches and schools.
Absolutely. And I don't want to run over. I want to set a good example for the rest of the committee. So I'm going to yield back and recognize Ranking Member Sparks for 5 minutes for your questions.
Thank you, Madam Chair. Mr. Roy, in your testimony, you say that the most significant mistake that the government has made is its inability to properly assess risk. As you know very well, government has never been known for its extraordinary ability to assess risk or strategically plan or be efficient or effective. Even not for extraordinary ability of common sense too, it's inherently political. So if you look at this, and what do you believe we could do to have a better mechanism to deal with the pandemic, engage better with private enterprise and have a more effective way to do it, and have more risk-based, not politics-based approach to deal with the pandemic? Do you have any suggestions?
Well, it's a great question, Ms. Sparks, because as you say, this is a very challenging problem. And public health is one of those roles or functions that government needs to be involved in. So it's not something you can just say, well, the private sector should just handle it, right? There needs to be a better approach to risk management from the government. I'd say two things. One, we need a much better CDC. The CDC from beginning to end has had a lot of problems, both in terms of suppressing private sector efforts to develop tests for COVID, to their ability to collect timely data that basically the Trump administration had to create a completely different data architecture using private sector companies to help in order to compensate for the problems that the CDC had in terms of providing real-time data to the government and to providers. And I'd say the last thing is it's incredibly important that we have an open debate about the risks and benefits of various interventions when it comes to public health. We did a lot in the last 12 to 18 months to suppress honest scientific debate about how best to approach this problem. And that created more skepticism, that created more mistrust, and actually also prevented us from identifying the best solutions where they were appropriate.
Thank you. If you look at that, I mean, we would have a challenge with open debate, which should be, the democracy where debate is encouraged, but we don't have that. We have a very politicized problem right now. So what are the things you would think could help us to have that debate? How we can build that transparency, have better data for people, and actually, have people trust in us a little bit more, because I have to tell you the truth, the level of trust on the ground from both sides is very low to our government. Any particular tools you could suggest? I read through your testimony, you bring a lot of very comprehensive risk assessment, looks at what are really societal risks, what are long-term risks, what are short-term risks, what are the other things maybe you can mention additionally to have an open debate and have reform in CDC and better maybe oversight of CDC by Congress?
Right. Well, absolutely. Look, I mean, risk assessment is a challenge for human beings in general. So we can't overestimate our ability to solve this problem through public policy. Having said that, I think the tech platforms in particular have a lot of responsibility for suppressing the data, egged on and encouraged by important government officials and policymakers. That's a serious problem we need to revisit. I testified last year in a hearing about this problem of the CDC and information gathering. I'm happy to share that testimony with the committee, where again, the CDC and the HHS tried to solve this problem, and they were accused of being political. They were accused because they were trying to solve a problem the CDC failed to solve. It was the people who were trying to fix the problem that were being accused of being political. When it was the other way around, the CDC was the problem, and the administration was trying to be responsible in fixing it. So I think we just need to tone down the partisanship on some level and just say, you know what, there are a lot of people who are trying in very challenging circumstances to solve these problems. And the temptation is always to be partisan in Washington, I know, but lowering the temperature and trying to find opportunities for good faith engagement with the other side, that probably would make a big difference.
Well, I appreciate it. Hopefully we can have this deliberation and debate, because, in the recent polls, it shows that public trust in Joe Biden's administration is significantly going low and low. And we have a less and less trust, and it's very unhealthy for people to have such a low trust to our government. So we'll be happy to work with you if you can share some information and provide it to this administration, to CDC, to have it better, because we have to combat and deal with it better. So thank you very much, and I yield back.
Thank you, Ranking Member Sparks. I now recognize the chair of the subcommittee, Mr. Desaulnier, for 5 minutes for your questions.
Thank you, Madam Chair. And I'd love to have that kind of conversation. I think we all would. A civil, lively conversation and evidence-based. So, Mr. Roy, I'm going to reach out to you and Congresswoman Sparks. I'd love to have not so much a debate, but a conversation. I believe in evidence-based research. We've shown that in judicial reform, criminal justice reform. That would be good if we could do it for public health. I'm a person who believes that there's a lot in human institutions. As you said, Mr. Roy, there's some struggles as we as humans, and I don't think the private sector has a monopoly on transparency, honesty, or integrity either. I don't need to go through a list of the corporations that have let us down. And I think there are a lot of good, amazing public employees and institutions. And in my district, the district I'm so proud to represent, having come from local government, I'm particularly proud of our public health department and the partnership it has with other providers. Kaiser is started in the East Bay in San Francisco. We have a very strong partnership with them and other private health providers. So, Dr. Purnell, one example we had was, and this is a long history we have in the East Bay and the Bay Area. Richmond, California is one of the poorest communities in a very wealthy area. And our public health department decided, based on long history, not with pandemics, but with public health, to do mobile drive-through clinics. We know that people in poverty, people of color, whether they're trying to get to work, get a job, get their kids to school, they have more obstacles than other people. And doing things like this is obvious to me. So Dr. Purnell, to reach communities with limited access to reliable transportation, limited access to technologies, what strategies do you think can be used, and point to specific cases, if you can, to increase COVID-19 vaccinations and booster shots and trust in the public health system?
Thank you. Very, very good question. I'm going to start with, again, we cannot afford to practice healthcare or public health from an ahistorical or an inauthentic perspective. And it becomes inauthentic when we don't recognize the truth, the lived experiences, and the narratives of those lives in the public. If you just look at our community here in Newark, a social cultural gym, a very diverse community. What has led to increased vaccination rates is taking the vaccines to the people, whether that is partnerships with churches, partnership with local government, partnership with institutions like my own, partnership with community-based organizations, leading in an asset-informed approach. Too much of healthcare is from a deficit approach. And what the deficit approach is, what a person or community lacks, and a provider coming in to plug that gap. When there are assets and resources in community, there are trusted messengers in community. So we have to find those trusted messengers. We have to partner with them and amplify their voices and share power with them. So for instance, we use a prevention army or a pop-up model. In our pop-up model, we are partnering with a CBO or we are partnering with a church that can bring people to the table who need particular services. And oftentimes that is vaccines in this climate. So whether it's through our partnership with the state, where we have ambassadors that go out into community to meet people where they are, knocking on doors to provide vaccines through a mobile vaccine unit, or whether it is opening up a vaccination clinic in our own parking lot, or the state has done that in Trenton, where community can see institutions share power, communities are able to trust and to say this care interaction will be meaningful and this care interaction is done with me in mind.
Doctor, can we talk a little bit about, just to follow up, community action agencies and non-governmental agencies, this partnership? Many years ago, I remember doing outreach again in the Bay Area to low-income communities of color on air quality. And it was striking to me that our public agencies sent public information officers into those communities who looked like me, and they were shocked that the community didn't embrace them. So we talked about cultural competency, but more than that, going to these nonprofits that are not just culturally competent, but are from the community to engage.
Definitely, that's sharing power. That's what you're describing, Chairman, and we need to do more of that, especially with historically excluded and stigmatized groups. Share power by identifying assets or resources already in community, already with a track record, already equipped with some currency or value or power that we can then marry our power with as an organization or institution. And that's how we begin to demonstrate accountability.
Yeah, it's wonderful. As a white male, sort of funny in a way for me personally to go to those meetings and subsequent more and see how defensive the institutions were and people who weren't from that community, that didn't have that life experience. And then when you, however you're able to break through that, the power when everyone respects one another and understands they're coming from a distinctly different place. Thank you so much. Thank you, Madam Chair. Now you back.
Thank you, Mr. Ranking Member. And I'm going to turn it over to Ranking Member Allen for 5 minutes for your question. I do want to note we have the chairman of the full committee, Congressman Bobby Scott, with us, as well as the Ranking Member, Representative Virginia Fox. It's my understanding that the full committee chairman and ranking member would like to ask questions later. If that's not correct, wave or send me a note and we'll get you in sooner. I'll turn it over to ranking member Allen.
Thank you, Chairwoman. And Mr. Roy, as I always learn a lot from these hearings. And as I reflect back on the confusion through this whole process, I remember doing a press conference in February in my district with our public health officials. And basically, the risk assessment then was that we probably would not be severely infected by this virus. We know it exists, but it's really not anything we should be concerned about. And then all of a sudden in March, I go to a briefing and the experts say that we could lose as many as 3 million people. It would collapse our healthcare system and our economy. Typically in a crisis, this nation comes together. I have never seen us so divided in this process. And again, I lay most of that right here at the feet of Congress and the White House and the Senate, because it's up to us to try to bring this nation together. But a lot of it is perception and also the fact that we have this disagreement between private medicine and public medicine. I mean, when the Trump administration said they were going to produce these vaccines, the public medicine people and many folks on the other side of the aisle said, that's ridiculous. You can't do that. So the Trump administration had to go to the private sector to get this done. And it was, everyone says, what a miracle it was. But then all of a sudden, there was this confusion about, well, if the Trump administration produces a vaccine, we're not going to take that vaccine. And these are leaders of our country. So, some have embraced the COVID-19 precautions and they've made it a part of their identity. They are now reluctant to return to normal life. How do we as a nation break through this new culture of fear mongering regarding COVID-19 and return to the greatest economy in the history of the world that we had? And we had, the greatest income growth among low income people in the world. How do we get over this?
Well, in my last set of questions with Ms. Sparks, we were talking about the issue of risk, right? And look, Americans are going to have different approaches in terms of their risk, their fear. We're not going to have a homogenous reaction that way. But I think where public health and policymaking leadership failed last year is in not making those distinctions between the risks of, say, children and the risks of people living in long-term care facilities. As I detail in my written testimony, there was a huge gap between the actual evidence in that regard and Americans' perception of their risk. That was driven by a lot of factors. Journalism played a role in that as well. But I mean, I think all we can do is just try to be more evidence-based, right? I mean, it really just try to emphasize to everyone who has an ability to influence Americans' attitudes, let's be evidence-based. Let's make sure that, for example, when we closed everything but quote unquote essential businesses, well, there were lots of so-called non-essential businesses that were capable of operating safely, as we detailed in a very long report we published in April of last year. So that was an example of where we were just not taking the risk into account and the evidence into account. So look, Americans are going to have a broad range of attitudes, but policymakers have a special responsibility to be evidence-based, and we didn't pass that test last year.
Well, you obviously were involved in the pre-pandemic levels of economic growth. I mean, we had record low unemployment across the board, including Black, Hispanic, and Asian workers. What significant policies and economic conditions resulted in the historically low rates which existed before the pandemic? I mean, what drove that? Because there's a lot of discussion about, okay, where do we go from here? I like history. I like what works. Tell us what your experience was with that.
It's a great question, Mr. Allen, to bring it back again to previous testimony I've given to this committee and to Congress. The record unemployment rates were amazing in terms of the relative unemployment rates, not just low unemployment rates in general, but the disparity between white unemployment rates and non-white unemployment rates had reached record lows right before the pandemic, and then of course spiked up. And so the lockdowns were particularly tragic for lower and middle income Americans, because if you're a white collar American, you can work from your laptop, good for you. But for people who have jobs that require them to actually be in that physical workplace, that's a different matter. Now, look, again, there was a public health role, and we have to be careful about sporting events, say, or bars maybe. But there were plenty of things that we could have done safely, and we needed to work harder to try to find those areas to reopen the economy. Why is that important? Because of what we've talked about already, the issue of trust, right? When you do things to lock down businesses and close schools that clearly have no relationship to the science, you can't then demand that people trust you about vaccines, right? They're not going to.
Exactly.
And that's why there's so much mistrust right now. And that's tragic.
Yes, thank you. And I yield back.
Thank you, Ranking Member Allen. Next, we're going to Representative Courtney. Representative Courtney, you're recognized for 5 minutes for your questions.
Thank you, Madam Chair, and thank you to all the witnesses for being here today. I come from the state of Connecticut, which this morning, in terms of the latest data, we're at 80% vaccination as a state for population 18 and up. We have the lowest infection rate of any state in the country, 14 per 100,000. So, when I listen to some of the witnesses talk about how, there was some, structural sort of divide that was taking place. I come from a state where the governor, public health experts at Yale, the state public health department, and our friends at Pfizer, who were very involved in terms of developing the vaccination. We have about 4,000 employees there that were part of this amazing effort that was there. In fact, the public-private collaboration is fantastic, and the results speak for themselves. This morning, the superintendent of the Coast Guard Academy in New London, Connecticut, met with a bunch of us. 99% vaccination rate on the campus. The submarine base in Groton with 10,000 sailors, that's there is over 90% vaccination. That's why they haven't missed one submarine deployment throughout the entire pandemic. They followed strict rules, which were difficult, particularly in submarines, which you can't, social distancing is impossible. But the fact of the matter is that for some of the testimony we're hearing today about how, there was this confusion that was, inherently driving suspicion and hesitancy. I would just say, coming from a state that has the lowest infection rate, lowest hospitalization rate in the country, in fact, people working together in the private and public sector, in fact, succeeded. And I would just note for some of the comments that were made that, the vaccine was the result of private sector investment. I mean, I kind of pinch myself. Back in March of 2020, when we passed the CARES Act, there was a huge allocation in there to develop the vaccine through the NIH. Moderna in particular, took advantage of those funds and was critical in terms of getting that drug approved by FDA and deployed out in the population. So the notion that this was, one way or the other is just, it's just, if you look at the chronology, you look at the forensics of how we got to this place in terms of a highly effective vaccine, and that by just basically, shedding all of the noise about, disinformation about the vaccine, you can actually succeed. And I'm very proud of my state in terms of the fact that we have brought those infections down. We have brought those hospitalizations down. However, last week we did actually have, in the name of debate, a hearing in Hartford where some state legislators brought in various witnesses. And Dr. Nguyen, you talked about how it is really important for public officials to combat disinformation. One frequent talking point that took place in Hartford last week was when the conversation came up about full authorization by the FDA for the Pfizer vaccine. There were a number of legislators who actually made the point that there was, in fact, only authorization for the quote unquote German vaccine, which presumably was BioNTech, which is where the research was done that developed the vaccine, but not the American Pfizer vaccine. And I see some smiles on people's faces, but that was repeated at a public event at the state capitol a number of times. So Dr. Wen, just for the record, can you clarify, is there any difference or anything such thing as a German Pfizer vaccine versus an American Pfizer vaccine?
No, Congressman, there is not. So there is a Pfizer BioNTech vaccine that is now given full approval by the Food and Drug Administration. The Moderna vaccine and the Johnson & Johnson vaccine both have emergency use authorization. It's expected that they will also receive full approval as well. And I think it's time for us to speak about the COVID vaccines as being no different than any of the other vaccines that our children, that we routinely receive. There really is not a difference. And we need to talk about COVID-19 as a disease like all other vaccine preventable diseases. And I think it's the statistics that you cite are so compelling that it is areas that have high vaccination rates that we're also seeing low rates of infection, hospitalization, and death.
Thank you. I yield back.
Thank you, Representative Courtney. And next time I'm going to recognize Representative Thompson. Representative Thompson, you're recognized for 5 minutes for your questions.
Madam Chair, thank you so much. Really appreciate this hearing. Thank you to all the witnesses, specifically Mr. Roy, thank you for being here today. You know, before 2020, the U.S. Economy and labor markets were strong. Real GDP increased 2.3% 2019 and 2.9% in 2018. The 3.5% unemployment rate in September 2019 was the lowest since 1969. However, due to COVID-19 and resulting state mandated shutdowns, there has been a dramatic negative impact on the economy, workers, and families. Now, as we begin to believe that this pandemic was in our rearview mirror and vaccines began to be developed and distributed through Operation Warp Speed, we face continued obstacles in getting our economy back on track. Additional mask mandates and lockdowns, as well as increased scrutiny on vaccination efficacy, are keeping us from returning to the pre-pandemic output and ultimately will create lasting impacts on our country. To make things worse, make things even more complicated, on September 9th, 2021, President Biden released a COVID-19 plan entitled, quote, "Path Out of the Pandemic," end quote, which includes a directive for the Occupational Safety and Health Administration to issue an emergency temporary standard on workplace COVID-19 vaccination. Now, this ETS will require all employers with 100 or more employees to ensure their workforce is fully vaccinated, or to require any workers who remain unvaccinated to produce a negative COVID-19 test result on at least a weekly basis before coming to work. Now, the administration estimates that the mandate will impact more than 80 million workers in the private sector. I don't think they know that private sector very well, and I'll get back to that. Having spent nearly 3 decades in the healthcare industry, I encourage everyone to weigh the benefits of receiving a vaccination and consult with our healthcare professionals. In fact, more than 445,000 people are fully vaccinated in the 14 counties that are all or partially in my congressional district. Now, the universe is not probably 680,000. It's less than that when you figure individuals or children who are not eligible for vaccination. So that's a significant number that I'm very proud of, actually. And every week, every day, we see more and more people becoming vaccinated. With that said, the pending ETS will likely cause many individuals to leave their jobs and create massive uncertainty, costs, and liabilities for many employers, particularly small businesses. I had a conversation yesterday with Secretary Tom Vilsack, Secretary of Agriculture. I serve as a ranking member on agriculture. And it was interesting. We talked about 5 different issues that are going on. I agreed with all 5 with the secretary. We're trying to figure out what we can do about those issues. And one of them is the disruption of the food supply chain to our schools. And that there are many schools, starting in large urban centers, they're starting to report difficulty getting reliable food in order to prepare the school meals, whether it's breakfast, lunch, or in some districts, actually dinner as well. And so as I dug deeper into that and reached out to my school districts, I found that even small rural school districts are having challenges with certain commodities. And I dug deeper and reached out to the industry, the food distribution industry. That one of the prevailing issues I'm hearing is workforce and the fact that these large companies with over 100 employees are losing workforce, specifically CDL drivers to be able to transport those food products and people working in warehouses. So the President Biden vaccine mandate for large companies is causing, it looks like, a significant, what I hope it will not be a significant impact, but somewhat of an impact on the access to nutrition for our children in schools, and certainly on our workforce, as people that are working for large companies, 100 or more, are making a transition to smaller companies. So I apologize that went so long, Mr. Roy. Can you talk with the time we have about the impacts of COVID-19 related restrictions on the American workforce that you see, and comment on the effects of those restrictions on small businesses versus large?
Well, just I'll try to be brief. So 2 things that I'd highlight from your comments. The first is, you all know this, but the public may not appreciate how much nutrition flows through the school lunch program. So when low-income students don't have in-person schooling, that's a big problem from a nutritional standpoint and a healthcare standpoint for a lot of those kids. On the workforce piece, there's a lot of problems logistically and legally with the federal government dragooning private companies to enforce a vaccine mandate. If the federal government wants to try to have a vaccine mandate, that's one thing, but companies should do it on their own. And I think there's a lot of problems with how those employers are going to be expected to enforce a mandate. What are they going to do? Are they supposed to fire people or get fined $700,000 per violation? I mean, this is a real problem, and there needs to be a proper comment period for that ETS.
Thank you, and I yield back.
Thank you, Representative Thompson, and thank you, Mr. Roy, for acknowledging the importance of those healthy school meals. We talk about that a lot on this committee. Next, I'm going to recognize Representative Adams. You're recognized for 5 minutes for your questions.
Thank you, Madam Chair. To also the ranking member, thank you as well. I want to first of all thank all the witnesses. You are all really great in your testimony. Your work in public health and in studying our communities as they continue to grapple with the pandemic is crucial to pursuing both public health-based and community-based solutions. So thank you for what you do. This hearing is a much-needed one, particularly as we look ahead and continue to work on protecting our loved ones. Dr. Martinez Bianchi, I represent North Carolina 12th District, which is in the Charlotte-Mecklenburg area. I appreciate the details that you offered today in your testimony, underscoring the importance of cultural competency in the context of vaccines for North Carolina. So in your research and from your observations, have you noticed discrepancies between access to information about vaccines between men and women? And as a follow-up, could you please speak to potential solutions to more effectively disseminate information about vaccines?
So we're doing, yes, I have seen differences, and I have seen the importance of that aspect of community engagement to listen to the community, to know what are their concerns. We have done a lot of work for many different groups. I'm testifying more about the Latino health, but for every group, the idea of sitting together and listening and understanding what are the questions. Initially, women had a lot of questions regarding the potential of vaccines affecting fertility. They had questions in regards to the potential of vaccines being problematic for a pregnancy, for example. But we have good data to support that actually vaccinating is healthier on the long term for women who may become pregnant, because pregnancy becomes a higher risk of a poor outcome. So yes, it is important to listen, to go on airwaves, but also to go directly to speak to people. Right. One of the approaches that we're doing is, if we're doing a vaccination event, do it together with the school district, with the public school, and together with a job fair. You need a job.
Okay, thank you very much. Let me move on, please. Thank you so much. Dr. Nguyen, you talked about various recommendations related to vaccines. Could you explain the steps that employers can take to protect vulnerable employees at the workplace, and also how employees can protect themselves at the workplace?
Thank you very much, Congresswoman Adams. So I think it's important for us to talk about this as layers of protection in the same way that we talk about layers of protection in the schoolroom. We also think about layers in the workplace. So indoor masking, for example, is an important layer of protection. Improving ventilation is another layer of protection. Very importantly, vaccination is a layer of protection as well. We know that vaccinated people are 5 times less likely to get infected with COVID compared to somebody who is unvaccinated. And so I would if I had to be in a conference room with a whole bunch of people, I would feel a lot better being in a conference room with people who are all vaccinated than compared to if they are unvaccinated. Also, at least weekly testing, but ideally twice weekly testing would also help to filter out those who end up testing positive and could be infecting others as well. And so I think it's the combination of these approaches. Right now, we're hearing from a lot of people who are from a vocal minority, if you will, who really oppose these types of measures. Maybe they oppose vaccine requirements or masking or something else. But I think we also have to remember that there is a much larger majority of individuals who really support these measures. And I think it is the duty of the federal government, of Congress, to ensure that workers are being kept safe.
Thank you very much. Dr. Purnell, how would equitable access to COVID-19 boosters protect the hard-fought gains in the COVID-19 increased vaccine rates that we've seen in communities of color? I have about 30 seconds.
Thank you, Congresswoman. I think I would point to specifically, we can't only focus on age, but we must look at the intersectionality of age and race, right? So we should be thinking about how historically excluded groups like Black elders or Latino elders, how they have access to care and specifically access to boosters. Do they understand that they are now eligible for boosters? Are we partnering with churches? Are we partnering with CBOs? Are we partnering with civic organizations to make sure that that information is culturally and socially fluent and that it's plain spoken and they understand the importance of a booster in particular in that age group?
Great. Thank you very much. And Madam Chair, I'm out of time and I'm going to yield back.
Thank you, Representative Adams. And next, I no longer see Mr. Walberg. Mr. Banks, you're recognized for 5 minutes for your questions.
Thank you, Madam Chair. In their testimonies, both Dr. Martinez-Bianchi and Dr. Nguyen have advocated strongly for equity in vaccination rates among Hispanic and African American communities. However, state governments have already attempted to address disparities in infection and vaccination rates among minority communities. California has reserved 40% of its vaccines for its, quote, disadvantaged residents. Both Massachusetts and Connecticut have respectively reserved 20% and 10% of their vaccine supply for communities that rank high on the CDC's Social Vulnerability Index. Despite these outreach efforts, minority and disadvantaged populations still see lower vaccination rates than other communities. Mr. Roy, can you explain why government-led top-down approaches are ineffective at reaching these communities?
Well, first of all, I want to say that I think it's immoral for the government on a racial basis to say certain people are going to be eligible for the vaccines and others are not. It's arguably a violation of the Civil Rights Act of 1964. And when vaccines were scarce, that was a serious problem. And I hope there's litigation that comes out of that to address that principle. Having said that, today, vaccines fortunately are not scarce, and everybody who wants to get vaccinated can. And we've already heard some of the stories, success stories of places where broad-based vaccination is happening. As you know, Mr. Banks, as I think everyone on this committee knows, there's a lot of mistrust in particular minority communities, particularly African Americans, because of a lot of checkered history that we have when it comes to public health and race. And so there is understandable hesitancy that all we can do is, I think, as Dr. Martinez mentioned, is try to do more to reach out, meet people where they are, have people, trusted figures in the community, address things that are not. That's not something that the government can do as a mandate, right? That's something you can't force people to overcome their trust. They have to do it on their own. So I think these are hard problems to solve. We can only overcome it one step at a time. But I think we got to start by just making sure that the vaccine is accessible and affordable to everyone.
Thank you for that. I know the Representative Allen touched on this a little bit already, but I want to dive a little bit deeper on this next subject. President Trump's Operation Warp Speed produced the COVID-19 vaccine in record time, delivering the first vaccines within 8 months of beginning the operation. Despite its success, Democrats sowed doubt and confusion over its effectiveness. For example, Representative Ilhan Omar, who sits on this committee, said, quote, "We can't trust the president and take his word and take a vaccine that might cause harm to us," end quote. Vice President Kamala Harris said during a televised debate, quote, "If Trump tells us to take a vaccine, I won't take it," end quote. President Joe Biden was also opposed to this vaccine prior to the election, stating, quote, "If and when a vaccine comes, it's not likely to go through all the tests and the trials that are needed to be done. Who's going to be the first one to get in line and take it?" he asked, end quote. Mr. Roy, what effect did these statements have on minority communities who overwhelmingly look to Democrat politicians for guidance?
This was a tragic series of events, Mr. Banks, and the reason why it was tragic is that we could have gotten FDA authorization of the vaccine sooner had there not been this cloud of, well, if the FDA approves the vaccine sooner, that must be because Trump made the FDA do it, not because it was scientifically warranted. And there are probably tens of thousands of Americans who would still be alive today if we'd gotten that vaccine several weeks earlier than we actually did for those particularly at-risk communities, the nursing home residents that we've talked about. So that was super damaging. How it affects vaccine hesitancy today, who knows, but clearly there must be some effect.
That's a powerful answer. I appreciate those answers. And with that, Madam Chair, I'll yield back.
Next, I'm going to recognize the chairman of the full committee. Chairman Scott, you're recognized for 5 minutes for your questions.
Thank you, Madam Chair. First of all, I serve on the budget, also serve on the budget committee, and would like to get one thing on the record: the great economy that was in the first 3 years of the Trump administration. I think we need to put on the record the fact that not any of those 3 years produced as many jobs as any of the last 3 years of the Obama administration. All of the last 3 years, the administration of Barack Obama produced more jobs than all of the jobs created in any of the first 3 years of President Trump. So they talk about a raging economy. I mean, that's just not the facts. Dr. Purnell, what barriers exist to in the minority communities to people deciding to accept the vaccine?
Thank you, sir. And I just want to say first and foremost, thank you for representing the area where my beloved father was born. My father was born in Newport News. So I wanted to say that and acknowledge him. I got to say this, and I got to make this clear. Race matters because racism exists. We have Black women dying disproportionately in maternal mortality. We have Black people who died prematurely on average of 200 a day. We saw disparities in this pandemic that caused earthquakes of devastation in Black and Brown communities. That history, that truth, we must start there. This is a conversation about equity. We must start there in order to build trust. When you have conversations with communities and you minimize their experiences, or you minimize their histories, or you minimize their truths, they can't trust you. Institutions, systems, hospitals, government, we must practice accountability. And with that accountability must be authenticity. So those barriers are historical, those barriers are contemporary, those barriers are rooted in access issues, whether those are informational issues around access, whether those are convenience and time-based issues around access. We have to show people that we are not ignorant of the truth of what they live through and then design solutions. That's what you saw happen in Newark. Now in Newark currently, there are 72% of Newark residents aged 12 and over that have had at least one vaccine dose. There are 60% that are fully vaccinated. That didn't happen by magic. That happened because of equity-based solutions to get to people who have been historically stigmatized and disadvantaged.
Well, thank you. I think Hampton University, Norfolk State, and Eastern Virginia Medical School are doing some of the same things. Dr. Nguyen, what's wrong with local control and personal choice on vaccinations, especially in the healthcare area?
I thank you for that question, Chairman Scott. I think that there has been this unfortunate narrative that vaccines are only a personal choice, just as choosing to eat unhealthy foods or smoking may be seen as a personal choice. Here's the thing, you can choose to remain unvaccinated. The problem, though, is if you then choose to go out in public, you are potentially infecting others with a deadly disease that has already caused more than 675,000 lives here in America. I've actually equated with my colleague, Sam Wong, a neuroscientist at Princeton, with the following analogy, that the choice to remain unvaccinated should be seen as being equivalent to drunk driving. Because you have a choice to be intoxicated, but once you get behind the wheel of that car and have the potential to impact other people, that no longer is seen as a personal choice. And I think when you consider about the individuals who are going into work and are now going to conference rooms or other settings with unvaccinated, unmasked individuals, and then potentially bring that home to their family, to elderly relatives, to young children who are too young to be vaccinated, that is a serious concern. And I just also want to say, we really need to consider the health of our unvaccinated children as well. I very much disagree with Mr. Roy in this respect. As the mom of 2 young kids, I'm very concerned that 27% of new cases are in children. The increase in the number of COVID cases is in children is 26% now compared to earlier in June, and we have to do everything we can to protect our most vulnerable, including our children.
And can you say a word about the vaccinations in the healthcare industry?
We require vaccines for healthcare workers. We have to take a flu vaccine every year. We have to take hepatitis, measles, mumps, rubella vaccines. The COVID vaccine should be required, as all others are.
Thank you, Madam Chair.
Thank you, Chairman Scott. And now I recognize Mr. Wahlberg for 5 minutes for your questions.
I thank the chairman and thanks to the panel for being here, though I must admit, I am just absolutely astounded by the unwillingness to deal with science and accept science and not make up statistics and disregard other statistics. It's just unbelievable. And I've been vaccinated and I've had COVID, so I'm not mining the issue of believing in reality, but my gracious, let me ask the questions. Thank you. Mr. Roy, the Biden administration has decided the best way to get more people vaccinated is to impose a private sector vaccine mandate enforced through an emergency temporary standard issued by Occupational Safety and Health Administration. However, you note in your testimony that the Biden administration should re-examine its efforts to impose a federal vaccine mandate on private businesses. Would you please elaborate further on that recommendation? What challenges will such an order place on businesses, both large and small? And what would you say is a better way to reach vaccine hesitant communities rather than through a federal mandate?
Well, we've talked a lot about how to reach vaccine hesitant communities today. In terms of the OSHA mandate specifically, there's a lot of problems with it. Leaving aside the legal problems, which we've addressed earlier, let me talk about just the practical and logistical and economic problems. So again, if you're an employer and you're now being told, well, you must vaccinate everyone, but there will be a violation. Exactly how does that work? If somebody refuses to get vaccinated, it's your fault as an employer for not forcing them to. How is that your role as an employer? That's a violation of all sorts of other laws. What about previously infected people who've recovered from COVID? There's a lot of evidence. The Israeli study found that after 6 months, people who've previously been infected and recovered from COVID have 13 times less likelihood of reinfection or breakthrough infection than people who are vaccinated who were never infected previously. So why don't we take that into account both in our official vaccination statistics and in the performance of employers? Then there's the cost to these businesses, right? What if you are in a business where labor shortages is a real problem? And now you're exacerbating those labor shortages by basically driving people out of the workforce. That's a big problem too. So, it would be one thing if we were talking about the nursing home facilities where they're funded by Medicare. We're talking about federal workers. There's a clear legal authority for the government, right? When you talk about private employers, it's much dicier. And there, I think focusing on high risk occupations for COVID and working with those employers to help them vaccinate their workers would be a much better approach.
And believing the statistics. Mr. Roy, the media often portray public health as being in tension with reopenings and a return to normal activities as we deal with COVID-19. Do you see it that way? And how can public health policies and a recovering economy work together to improve the lives of all Americans?
There's absolutely is the answer. And we wrote a lot about this at my think tank FreeOp last year. I testified, I think, 8 times on this topic. You know, we spent a lot of time walking people through exactly from an evidence-based standpoint how you could reopen the economy safely while also making sure high-risk activities, we were being more cautious, we were being more prudent, more evidence-based. So that absolutely was possible then. It's certainly possible now. States that have reopened have, broadly speaking, had a good experience with that. And I talk about in my written testimony how California, which was excessively restricted, had basically the same rates of cases and deaths as Texas and Florida did. It's a little different now because vaccination rates are playing a role in all these stats. But last year when we didn't have a vaccine, restrictions were not correlated at all to performance in terms of deaths and cases from COVID. And so we have to have some humility. I think when policymakers say we're going to do X, we must do X, and if you disagree, we're going to censor you, that's a real problem. We have to have a humility where we say, you know what, we're going to look at evidence, we're going to revise our opinions based on the facts, and we're going to tolerate different approaches. It's good that we had 50 states trying different things so that we could optimize for reopening schools and reopening workplaces. And those who did so in a data-driven way have been very successful with it.
And in schools, what an important area that is, and don't have much time to touch on it, but how can we relate that risk versus reward, having kids in the classroom, having parents back to work, and still dealing with this pandemic?
Listen, I'm a father of young children too, and my 2 children are in school, and I'm so glad that they are, because I can't imagine what the loss of the last 18 months would have been had they not had the opportunity to get educated at that tender age. It's so important to their brain development, to their emotional health, to their social development, to their long-term economic and health outcomes. The evidence is overwhelming, not just in the United States, but around the world. We did a study last year. We looked at every major industrialized country and showed that there were no risks of additional outbreaks from COVID based on school reopenings or school closures. And that still holds true today.
Thanks. My time has expired. I yield back.
Thank you. I now recognize Representative Wild. Representative Wild, you're recognized for 5 minutes for your questions.
Thank you so much. And this is directed to all of the witnesses. I want to talk about 2 of our most at-risk populations, the homeless and people with disabilities. In many places, there was unequal access to vaccines, and vaccines for individuals in the disability community and our homeless population. The focus on center-based distribution has made it difficult for folks, at least in my district, who are homebound or homeless to get testing or vaccines. We have helped my office, a number of individuals who wanted a vaccine but could not get an appointment. And I know that sounds almost incredulous given the widespread availability of vaccines, but again, at this point, it's a matter of getting them to the people who have trouble getting to these centers and that kind of thing. So I'm just wondering what lessons have been learned that you've seen that we can apply to continue to fight the pandemic for our homeless and people with disabilities. And anybody that wants to take that?
Sure.
So if I may, go ahead, Dr. Purnell.
Thank you. I'll start with some of the things that we've been doing here at University Hospital, even pre-pandemic. What we know is important is having those navigators in care who are socially and culturally fluent and aware of the different disparities that unique groups face and around those experiencing homelessness. So we have a program called Familiar Faces in our population health, where we pair a community healthcare chaplain that checks in with persons either going physically pre-pandemic to where they are, whether they're housed or unhoused, or a person who can walk you through the care process. And I can't stress this enough. The prevention model is that you must bring care out of brick and mortar institutions and bring care to where people are, on the front lines of their lives, whether that life is underneath a bridge or that life is in a house a housing scenario that is more standard. And if we learned anything from this pandemic, is that we cannot afford to practice care from this oblivious place that says that everybody needs care or should receive care in the same way. The more we can specialize and customize, that's when we begin to have equitable approaches. And we will continue to do that. If we don't, we will continue to lose lives disparately.
I've been very impressed by communities that are doing essentially door-to-door vaccinations and that kind of thing. And I'll let anybody else who wants to respond to that previous question do so. But I also wanted to add to my question whether that is potentially a way of getting past what we're still calling vaccine hesitancy. I don't know if that's the right term anymore. But if people are directly approached, are they any more likely to be willing to get the vaccination? And again, I'll open it up to anybody here who wants to answer.
Well, what we're seeing both in our primary healthcare offices and going to door to door, when our community health workers are going to door canvassing, they are always asking, when you have somebody who's convinced and ready, this is the moment to get that vaccine. And bringing the vaccine to the home of those who are homebound or to campsites if there are homeless communities is key to be able to reach these communities. And then the other issue is making sure that as we are deploying, that we are planning and looking, where is it, who hasn't been involved, who hasn't been vaccinated, where are the groups, and having members of the community, representative of those communities, being part of the teams that are doing that mobile healthcare type of access. It's key if we have representatives of the community guiding the effort.
May I add one more thing? Actually, two more things. One is that we have actually seen incredible stories from contact tracers who are talking to people about quarantining and isolation. And they're also finding out about individuals' needs when it comes to food and housing, and even people who have concerns about domestic violence. And I think that just really underscores the importance of care navigators more broadly in assisting with public health needs. The other issue, though, to your direct question, Congressman Wild, I do think that it's really important to reach people where they are in their homes. But in many communities around the country, public health officials have been, and public health workers on the ground have actually been assaulted or harassed or turned away because of the rampant misinformation and disinformation. So I hope that more will be done to protect those individuals who are just really trying to do their job and deliver care to the most vulnerable.
Thank you. And I think you're absolutely right about that. And Dr. Purnell, your comments about making sure that we are accompanying it with culturally competent individuals to deliver this care, I think is really, really important. With that, Madam Chair, I yield back. Thank you so much.
Thank you. I now recognize Representative McLean for 5 minutes for your questions.
Thank you, Madam Chair. You know, as I sit here and I listen to everybody today, I think we all, or at least I think we all are on the same page that we want to do what's right for our children and the Americans, and we all want to work together. We respect COVID, but I think at times we need to fear it a little less and have a little bit more faith in the American people and in the doctors. And I believe most people are good and not perfect, but I believe we've made tremendous strides and tremendous progress. And I'll lead with this is one of the lessons my mom told me growing up, you catch a lot more bees with honey than you do vinegar. So, I mean, I think one of the biggest issues that I've seen in government is the American people want some truth, some transparency, and a heck of a lot more consistency. And if we can all come together on truth, transparency, and consistency, and truly follow the science, I think the American people would be a heck of a lot more apt to jump on board. You know, I look at this as during the campaign, Vice President Harris said over and over again that, you know, don't trust the vaccine developed under President Trump. And now we have 3 vaccines under Trump's Operation Warp Speed. And the Biden administration has been begging people, now forcing people to get vaccinated with these very vaccines that he railed against for months. So, have a little empathy for the Americans who you can't say, oh my God, I'd never get the vaccine, and then turn around and mandate it. A little consistency would go a long way. And Mr. Roy, I'm asking you, how can the American people trust the administration's message on vaccines if we continue to talk out of both sides of our mouth?
In my written testimony, Ms. McClain, I brought up the point about, the CDC had this panic after the Provincetown outbreak and vaccinated, some of whom were vaccinated individuals. And all of a sudden, it was like vaccines don't work anymore, right? Oh gosh, we've got to go back to locking down and hiding in your basement and wearing a mask in outdoors. Because if you don't wear a mask outdoors and you're vaccinated, God forbid, you might get COVID. I mean, it was just insane, right? And so how could you be surprised that there's vaccine skepticism when you have the CDC saying, wear a mask outdoors, even if you're vaccinated, right? So that's a big problem. And, it goes back to things that happened last year. Dr. Fauci said, don't wear a mask. Then he said, wear a mask and mandate it, right? The World Health Organization said the same. And again, look, I can understand the evidence changes. You're going to revise your opinion. That's fine. But then have some humility as we go through the process instead of saying, do what I'm saying now, or you're this ignoramus. Instead, say, the evidence suggests we should do this. The evidence may change over time, but this is our best assessment of the evidence today. And our best assessment of the evidence today is that if you are vaccinated and you are outdoors, you are almost certainly safe.
Well, thank you. I do believe in the American parent as well. So I believe actually the parents are probably most qualified to parent their children. And this is where I think we need to bring them inclusive into these conversations, because I don't believe any parent would intentionally want to do harm to their child. And we need to begin to treat them that way. But Dr. Wen, this is for you. I'm trying to get our federal government to finally provide some consistency and transparency with information regarding COVID. The administration says get vaccinated and wear a mask. My constituents are receiving mixed messages because they interpret the message from the president with that being the vaccines don't work, which I think we can show that the vaccines do work. Then why the mixed message on the masks? Now, some school districts are mandating vaccines for students before they even return to the class. My question is this: who is better suited to make the calls for the health of their child? A school superintendent or the parent? See, I think we're missing this parent. We need to bring the parents closer.
Was that for me, Congresswoman?
Yes. Yes.
Apologize. Thank you. I'm a parent also. I have two little kids, ages 1 and 4. My 4-year-old just started back in preschool in person. I am very thankful that my preschool requires many layers of mitigation, that it requires indoor masking. And so I think it's a combination. I think that
superintendent to make the decision as opposed to you.
I think that we need to recognize what impacts my child is not just my decision, it's also the decisions of other parents around us.
You prefer to defer that and make a community decision on what's best for your children as opposed to the parent. I'm okay with the answer. I'm just trying to understand, because the parents in my district believe that they're the best people to make the recommendations for their parents. So I appreciate that. Would a child's doctor know what's best for their child, or would the school superintendent know what's better?
Representative McClain, your time is expired. We've let you go over a bit, but I'm going to
thank you very
move on
much.
to yeah, of course. Move on to Representative Hayes. You're recognized for 5 minutes for your questions.
Actually, I think Representative McBath is.
I apologize. You're absolutely right. I recognize Representative McBath for 5 minutes for your questions.
Thank you so much, Madam Chair. And thank you to our guests who've joined us to talk about this really very pressing matter. And for the last year and a half now, this pandemic has just caused grief for many, and financial difficulty for millions, and of course, drastic changes to the lives of every single American family. Even recently, hospitals in my home state of Georgia are so full of sick COVID patients that they've had to postpone elective surgeries. I think we've seen that around the country. And, there's still so much more work that remains to be done. And so I thank you for taking the time to come to Congress and to share your expertise with us this morning. I remain convinced that increasing the number of vaccinated individuals is absolutely the key to our recovery, both for our economy and for our health. And according to the recent data from Kaiser Family Foundation, only about 25% of unvaccinated adults plan to get a COVID-19 vaccine by the end of the year. And we've also seen a growing increase in partisan polarization around the vaccine and negative feedback loops from different information ecosystems. Dr. Wen, my question is for you. Emergency physicians, nurses, and other healthcare workers have persevered for nearly 2 years now on the front lines. And with each departure, our nation's healthcare workforce loses an invaluable resource. And I believe that healthcare workers can also be a resource in improving our vaccination rate. How can we include more emergency physicians and first responders in community engagement efforts to share their experiences and to encourage COVID-19 vaccinations?
Thank you for that question, Congressman McBath. I very much agree with you that there are so many frontline healthcare workers who are burned out, who have been going through this and really see no end in sight. And there are so many healthcare systems that continue to be overwhelmed. And so I think there is a level of compassion fatigue that also exists. However, of course, it's our duty to always take care of our patients, no matter what choices they may or may not have made. I know that all my colleagues are united in continuing our education and outreach efforts, because that's not a choice for us. When we see patients coming in, it's our choice to help, or it's our job, our responsibility to assist them in every way. I think that part of it is also all of us embracing our responsibility too, because we are the most trusted messenger to someone. Doctors, nurses, pharmacists certainly are trusted messengers to their patients and to others, but we are also trusted messengers to somebody in our lives as well. And there are individuals, many of whom may have changed their minds on the vaccines, who I think we need to uplift their voices more. So many patients anecdotally that I've spoken to who said they changed their minds, it's because of an illness in a relative, or it's somebody that they knew who initially were not going to get vaccinated, but now got vaccinated. Telling those stories of change also helps a lot too.
Thank you. So, and also too, as policymakers, is there anything that you believe that we need to be doing more of to help create that kind of climate and environment across the nation? Because we're doing as much as we possibly can to create the funding and the policy and put forth that effort, but is there anything that you believe that we have left out that we need to continue to do to make sure that everyone is cared for and everyone is healthy?
Well, I do think that we need to continue talking about the layers of mitigation. There was brought up earlier about, well, why is it that vaccinated people might still be wearing masks in some circumstances? Well, it's because when we have this high level of transmission, we need multiple layers. And so understanding that vaccines are a layer, testing is a layer, masking may be a layer. When the rate of transmission goes down, we can remove some of these layers. I think having that holistic approach is really important.
Thank you. And one more question I will ask. If we are not to overcome, being able to get that message through to individuals across the country for whatever their reasons are not wanting to get vaccinated, what do you foresee for this nation going forward from a healthcare perspective with COVID-19?
We've already seen it. I mean, 1 in 500 Americans have already died from COVID. Right now, we have about 2,000 Americans dying every day. That means that within a year, if we sustain this pace, which I don't think we will, but if we sustain this pace, that's 700,000 Americans dying. I mean, I don't think any of us should find these numbers to be acceptable. We're seeing the Delta surge that was actually preventable because we didn't have high levels of vaccinations. If you asked me last year, it gave these numbers last year to me and said, well, what do you think about this? I would have said, oh, that means that we never got a vaccine, but we have a safe and effective vaccine. This is really tragic that we still are seeing this level of preventable suffering.
Well, thank you so much. And I am out of time.
Thank you, Representative. I now recognize the ranking member of the full committee, Ranking Member Fox. You're recognized for 5 minutes.
Thank you, Madam Chair. I appreciate that. I want to thank all of our witnesses for being here today, especially Mr. Roy. Mr. Roy, you're of course asking for a lot when you ask for humility from elected officials. Most time you get hubris, which is what we're getting in terms of the mandates on so many things that are occurring in our culture these days. Mr. Roy, I'm concerned that our colleagues claim to be advocates for vulnerable communities have access to in-person learning, even though school closures have had a disproportionate impact on lower income communities and communities of color, the very people they pretend to care about. Can you speak to the effects of school closures on vulnerable communities?
Well, I discussed this a lot in my written testimony and I think in my oral testimony as well. Disproportionately, it's minority parents, minority children who have been affected by school closures. A lot of that's geographic, but it's been a huge problem. And that disparity is, it's interesting. Asian Americans are actually the group that has had the most disproportionately impacted by school closures. Next highest is African Americans, then Hispanics. Whites, 2/3 of white children are able to have in-person learning. So there's been a massive racial disparity in the ability, the opportunity that children have had to have in-person learning. And we all know that the virtual model at the elementary level, at the preschool level, the middle school level is just not working, right? It hasn't worked. And so that, you have kids who are being promoted to the next grade, having never actually attended school in the prior grade. How do you think they're going to do in the new grade, having not learned what happened in the last grade? These are kids we've effectively abandoned through the educational system. It's an incredible tragedy, and the untold losses economically and on a human level for those kids. I shudder to contemplate what the total damage is going to be. I'm just grateful that more and more schools are opening now.
Thank you. I was going to ask you a question about the mandates on employers, but you've done a very, very good job of acknowledging OSHA mandates and the challenge employers will face. And I don't think we can understate that. Mr. Roy, there's currently also an enormous shortage of COVID-19 rapid tests in the U.S. What will be the impact of this shortage on the business owners and workers when the OSHA vaccine and testing national mandate is implemented in the coming weeks?
That's an important question, Ms. Fox. I appreciate you raising it because we've heard a lot today and elsewhere about, well, if everyone should just have rapid tests all the time and then everything would be fine. Well, we can't just snap our fingers and get the supply chain to expand by the multiples it would need to expand to deliver that quantity of tests, let alone for the OSHA mandates that are forthcoming. So that's a real problem. And we're already seeing it. We're already seeing it. It used to be just a couple of weeks ago, prior to the Biden executive order, if you wanted to order a Binax test on Amazon.com, you could do it. I've done it. I have a stack of them at home. So for when I need them and when our family needs them, but you can't do that anymore. They're out because of the fact that this OSHA mandate has now led to the complete elimination of that extra supply. So if you're going to mandate that everyone get tested when we don't have the supply of tests to address that mandate, that's just asking for a catastrophe.
Well, just one more irresponsible decision and mandate that this administration has made in a long line of irresponsible decisions. We can remember, I think, Mr. Roy, the slogan, 2 weeks to slow the spread, in a rather ironic sense, given the prevalence of mass mandates and restrictions that continue in the U.S. In the early days of the pandemic, the goal was to keep hospitals from being overwhelmed. Today, community life continues to be impacted if even one case is discovered. At the start of the pandemic, Dr. Fauci said Americans needed 60 to 70% vaccination rate to reach herd immunity and return to normal. Yesterday, President Biden said our country needs to reach a 97 to 98 vaccination rate to return to normal. What do you think? Why do you think the goalposts keep changing?
Well, we don't know what level of immunity, what percentage of immunity is required to achieve herd immunity with COVID. I think a lot of theories have proven to be inaccurate over time. Having said that, it's extremely important that we not just look at vaccinated individuals, but as I've alluded to earlier, individuals who've successfully recovered from a prior COVID infection. That turns out to be significantly more protective than the vaccines. And that's not to encourage people to go out and get COVID, of course. But it does mean that people who have previous episodes of COVID infection, SARS-CoV-2 infection, should be counted towards that immunity status. So let's say we have 70% who've been fully vaccinated, another 27% who've been previously infected. That would be 97%, right? So include the previously infected in your totals, and then we can assess the situation.
A little more, it's more hubris and less humility. Thank you. I yield back, Madam Chair.
Thank you, Dr. Fox. Now I recognize Representative Hayes for 5 minutes for your questions.
Thank you, Madam Chair, and thank you to our witnesses for being here today. A couple points I want to make before I begin my questioning is, first of all, I don't think that the CDC has been disingenuous or dishonest as the information has changed throughout this pandemic. I don't think that the goalpost is moving. No one can endure this pandemic for 18 months and your position today be the same as it was a year and a half ago. As we learn new information, we evolve and we adapt and we respond to the information that we have right in front of us. I've heard several members quote President Biden or Dr. Fauci at different points, but let us not forget that the leader on vaccine skepticism was President Trump, who himself said just a month ago, I encourage everyone to get vaccinated. So as people are learning new information, they are evolving with the information that they have in front of them. So I just want to make that point. No one is attempting to mislead the American people or be dishonest. As we get new information, we are adjusting to the situation that we're in. The second point I want to bring up is that as a parent of a public school student and having been a teacher for 15 years, parents make the decision for their individual child. Superintendents have to make a decision for an entire school district. My superintendent had to make a decision for 19,000 children. She did that in conjunction with public health officials, with local officials, with our local hospitals, and did what she needed to do and continued to do what she needs to do for all of those children. Individual parents, their responsibility begins and ends at their child. When you are a school superintendent, you have a different level of responsibility. So that's why some of those decisions are being made. And I heard Mr. Roy talk about the disparities in different communities. You are absolutely right. My district has some of the largest equity gaps, and some of our schools were equipped to be up and running, open, full scale. They had the spacing, they had the HVAC systems, they had modern facilities. Those are things that we have tried to address and that we need to address. So all communities are not created equally. So that leads me to my questions today. In Connecticut, there are about 390,000 cases of COVID-19. 8,400 Connecticut residents have been lost to this virus. And to date, we had about 22,000 people in ICU hospital beds. And my state is doing well. We have 75% of people vaccinated and a governor who is incredibly proactive and always looking for solutions. But there are several socioeconomic and geographic factors that limit people's ability to be vaccinated. We've tried to include transportation, some of those other things, try to mitigate some of the problems. Dr. Nguyen, can you explain how community engagement and wraparound supports creates barriers and affects people's access to the vaccine? What that looks like and how we as federal legislators can facilitate greater community involvement so that more people can get vaccinated.
Representative Hayes, thank you for your for your work and for pointing out also that a strong public health response means that you are evolving to change your policies based on new data. That's not flip-flopping if you have new data. That's actually responding to the moment. I do think that having Congress help to combat misinformation is very important. Also supporting local efforts that Dr. Martinez-Bianchi, that Dr. Purnell and others have mentioned. There are so many examples of local partnerships. We need to trust the communities. I think that's something we should all be able to agree on, that people on the front lines people in the communities that they're serving know best about what works there. And when we see efforts that are successful in bringing vaccines to individuals experiencing homelessness or helping low-income families, we should be scaling up those efforts, and allowing maximal flexibility in funding for local communities is really essential.
Thank you. And really quickly, Dr. Purnell, when high-risk priority groups, we just saw that President Biden had guidance on booster shots. Can you tell us how those vulnerable populations will be impacted and how this booster shot guidance will affect them?
Great question, Congresswoman. I don't think we can emphasize enough that the disproportionate burdens that Black and Brown groups bear deserves, in particular, attention. And what I mean, I think we focus a lot on age, and we need to focus more on race. We need to stratify data by race, because what we see in Black and Brown communities is actually they are impacted at younger ages and younger rates. So I would be very interested to see how boosters are distributed among those populations that have been disproportionately burdened by disease, disproportionately burdened by disability due to this infection. I think it's going to be very, very important that we continue to do the things that we know works. What works is partnering and sharing power with community, explaining and making sure community understands the utility of boosters in those high-risk groups, those who have comorbidities, comorbid diseases, same community saddled with the diabetes, saddled with the high blood pressure.
Dr. Purnell, I'm really sorry. My time has expired, and I don't want the chair to be mad at me.
Not a chance, Representative.
Thank you. If you can submit the rest of that answer, I'm very interested in it. Thank you so much.
I now recognize Representative Harshbarger for 5 minutes for your questions.
Thank you, Chairwoman and Ranking Member, and thank you to the witnesses here today. I think I understand a lot of the confusion, and Mr. Roy, you tell me if I'm wrong in anything I say, because, it's really regrettable, but you correctly stated in your testimony that all this started back in the 2020 election when you had then President-elect Biden and Vice President Harris talking about how they didn't trust how the vaccines were developed. That's the first step. When you don't trust in how these are developed through Operation Warp Speed. And then you have the COVID guidance flip-flops on, do you wear a mask, do you not? Do you wear 2 masks, do you not? You have, how did the CDC set policies with, where are the studies at? If you want to follow the science, let's look at those studies. You've got the reported influence of the teachers unions on the CDC guidances. And that just happened when they said you don't have to have a mask mandate in schools, and now you do. We still don't know the origins of COVID, do we? As members of Congress, we don't have the hearings to hear that. And then you have the latest with the flip-flop from the FDA and the CDC on the boosters. And they say do it, and now there's different guidance. But what tops it all off is the vaccine mandate. And you are telling private employers that if you have 100 employers or more, you have to have them vaccinated or they don't have a job. And then you have your healthcare workers in your hospital systems. Your healthcare workers have to be vaccinated. I understand it. I'm a pharmacist, for God's sakes. I took the vaccine. I tell people we didn't cut corners, we cut red tape. Do the vaccine. But when you force them to do that, but you don't, you have over 200,000 people coming across the southern border illegally every month, and they are not, and I'm on Homeland too, so I know this is fact. They are not COVID tested, and they're not mandated to have that vaccine. And you wonder why Americans are hesitant? Well, I'll tell you, there's your sign. Does this sound like a mitigation strategy to you when that's based on science? And also there's being monoclonal antibodies that are going to be withheld from certain states, and we don't know why. There's no shortage in the supply from the manufacturers, but they negated not to ask that question to the manufacturers. And now there's several states that we don't have the supply that we need. And you tell me that's not political? There's a problem there. So if you would expound on that, and I'm in a rural district, and you don't think this is going to influence the healthcare workers and the employees that were already in short supply, our patients are not going to be taken care of. And I would like to, I'd ask unanimous consent to place into the hearing record a September 13th, 2021 Washington Post op-ed entitled, "In My Community, Biden's Vaccine Mandates Could Put More Lives at Risk." But if you could answer that, sir, about mitigation strategy and things like that, I could go into a whole lot more as far as natural immunity and things they should be doing. But you tell me what's wrong with anything I just said or what we need to correct.
Well, Ms. Hartford, you raised a lot of points. Let me try to, in the time we have, to focus on one or two. I think that, many of you in Congress are former or current business owners. And what business owner, what employer wants their workers to die of COVID or to become seriously ill of COVID? Zero. So this idea that somehow employers are the obstacle in getting their workers vaccinated is absolutely not the case. Every employer wants their workers to show up to work healthy and happy. That's in the absolute economic and human interest of every employer. So why don't we actually engage employers and learn from employers about the strategies they've succeeded with or failed with at getting their workers vaccinated? That seems to me a much better approach than what we're describing here, for all the reasons that we described. Now, I think that's such an important. We all want everyone to be protected from COVID-19. And the other piece I would bring up is something I alluded to in my last remarks, which is people who've recovered from COVID. Right, this is an important thing to track and to monitor. People who've recovered from COVID have a very compelling form of immunity. Generally speaking, obviously people who are immunocompromised or people who are elderly whose immune systems may not be as robust, there are always asterisks and things to take into account. But broadly speaking, recovering from COVID is a form of immunity more powerful in many cases than mRNA or other vaccines. So we should be taking that into account in our strategy and in our policies.
Absolutely. Antibody testing should be one of the things available to American public, and natural immunity, but we're not discussing that. So I know I'm out of time and I yield back.
Thank you, Representative. I now recognize Representative Levin for 5 minutes for your questions.
Thanks so much, Madam Chairwoman. I'll jump right in with first a few questions for Dr. Martinez-Bianchi. For many vulnerable communities, language barriers have kept COVID-19 testing and vaccination services out of reach. Without access to translators, what challenges have first responders and contact tracers faced while working to prevent COVID-19 outbreaks in communities with limited English proficiency?
So COVID definitely highlighted the language barriers. And some of the challenges have been that during a COVID pandemic, you're not able to really have your interpreter on the site at the same time. So often what first responders and physicians have done has to be using tablets or other ways of translation. This has really impacted the community, the Latino community, the trust, not having somebody. One of the deficits we have in the country is that how many children that are brown and Black have been historically excluded from health professionals as well. So we need to continue to work on getting more kids, more adults who are members of these minoritized communities to be able to be part of the health workforce. But the challenges are there.
Yeah, it's really exposed problems that were already there, hasn't it, in terms of access to healthcare? Well, what can states do? How can they improve access to dialect-specific language translation services to prevent disruptions, particularly to make sure people get their 2-dose vaccination series and other things?
One of the most brilliant things I have seen has been the contract in use of community health workers, contracted from the community, representatives of the community, often even language speakers of the language spoken in the community.
Yes.
And their representation of the community has earned a tremendous amount of trust. When we do vaccination events, and our community health workers representative of those communities are part of the canvassing and the encouragement and recruitment, we have much more success with vaccination, with access to care and to access to testing and the use of monoclonal antibodies as well.
Wow. I mean, I have to say that was a part of the proposal in Senator Warren's and my Coronavirus Containment Corps Act at the beginning of the pandemic. So I wish we'd gotten that through. Let me ask Dr. Purnell questions about this, as the thing we've been talking about to some extent, vaccine hesitancy. How have broad generalizations about vaccine hesitancy prompted widespread disengagement really from certain communities? And how can stakeholders involved in COVID-19 response efforts overcome communication hurdles and address vaccine-related concerns directly to ensure people receive COVID-19 vaccines? And as you get ready to respond, let me just say to my colleagues, I'd say some of the most meaningful moments in my life in the last months has been when I talk to someone who really believes in me or I have a real relationship with, and get them to get vaccinated, often right where we are, because there's a clinic related to an event. So Dr. Purnell, help us out here.
Definitely. I have had this conversation, as you can imagine, so frequently. And I can tell you, most people, Black people, brown people are no different. Most people in humanity want to be seen, heard, and validated. And we want to be understood for the fullness of our stories. And with that being said, there actually has been movement in Black and brown communities around vaccination. Whether we're talking about the mobile vaccination units that we've used here in the state, across 76 days, almost 3,000 shots. 50% of those shots have gone to Latinos or Hispanic persons. Another 30+% have gone to Black or African Americans. And that's because we've helped them along their decision journey. Black people, brown people, at baseline, we're not just hesitant. At baseline, we have history. At baseline, we have questions. At baseline, we want to feel heard. And so when we can navigate those conversations with that level of authenticity, with that level of transparency, we see movement. We see groups move. If you look at the Kaiser Family Foundation and you looked at the groups who were originally in that wait and see category, a lot of Black and brown persons were in that wait and see category. And we've seen conversion. We've seen conversion of that wait and see to already having been vaccinated. And the last thing that I would say, there is data that is becoming available that there has been significant improvement in the African American community. And perhaps as high as 70% of those in the African American community being vaccinated. And we're not telling that story enough. And the more we tell that story, it gives a sense of permission for others to say, hey, I have fears and concerns, but I got them addressed and I went ahead and I got vaccinated.
Thank you. Outstanding. Thanks, Madam Chairwoman. My time's expired. I yield back.
Thank you. And next I'm going to recognize Representative Fitzgerald. You're recognized for 5 minutes for your questions.
Thank you very much. Thank you very much. Mr. Roy, in your testimony, you stated nearly 40% of the deaths from COVID-19 occurred in 2020 were in long-term care facilities. I was in the Wisconsin State Legislature for the first part of the pandemic, and later on, between our Secretary of Health, Andrea Palm, who's now out in DC, obviously, and also with Governor Evers, they reclassified a lot of those deaths kind of in one large change that was made kind of across the board. And, I've heard of similar types of adjustments being made. So my question to you is, the misclassifying long-term care facilities, what they experienced, is this something that should continue to be investigated? And I don't even mean like in a legal way. I mean investigated so in the future, any of these types of major health crises in which any governmental entity is suddenly required to record this data does a much better job.
Both excellent questions, Mr. Fitzgerald. So on the first point, yes, there absolutely has been problems with misclassification. New York is one of the infamous examples where they basically said, if you got COVID in a nursing home, but you died in a hospital, we're going to count you as a hospital death, not a nursing home death. That was one of the ways in which New York engineered an undercount of its nursing home deaths, which was done apparently because the governor had mandated that people discharged from hospitals with active COVID infections must be put into nursing homes. Nursing homes were required to accept those individuals, which they objected to strenuously at the time. This was something we tracked at my think tank at the Foundation for Research on Equal Opportunity, because no one else was measuring this in the spring of 2020. So we actually scraped the data from every state to develop maps of, okay, where were these deaths happening? What share of the COVID deaths in each state were happening in nursing homes? And what was amazing is 11 states weren't even collecting the data, even though 40%, in some cases, a majority of the deaths were happening in long-term care facilities. So absolutely, we should look back. But in terms of looking forward, I think it's really important that we examine thoroughly how nursing homes protect their residents against infectious disease. This was a problem before COVID. COVID certainly brought to the surface, brought to the fore how bad this problem is. But this problem will continue in the future with other infectious diseases if we don't make some lemonade out of the lemon, so to speak, and just try to learn from what's happened here and try to improve the protocols that are in place in nursing homes and other long-term care facilities. Again, it can't be emphasized enough. 40% of the deaths in facilities that house 0.6% of Americans.
Yeah, just in a quick follow-up to that too. I mean, one of the other things we experienced in Wisconsin was that because there are many different levels of long-term care, obviously all the way from a nursing home, a full-blown nursing home, to some type of assisted living, the populations that kind of come and go in that environment, they vary. You know, you could have much younger individuals who could be carrying in one environment, and there's really no cross-check there. And I don't know if that's something else you saw based on the type of environment and what their experiences were.
Yeah, absolutely. More of the deaths proportionally occurred among more medically vulnerable and disabled elderly populations. So nursing homes, most seriously, assisted living facilities would be next, and so on. So, you have to look at it that way and tier accordingly. But again, medically vulnerable populations, medically vulnerable elderly populations was where there was enormous risk. And if we had spent all this energy locking down the economy and closing schools on protecting medically vulnerable seniors, we could have done a lot better.
Thank you very much. And I yield back. Thank you.
Thank you, Representative. I now recognize Representative Stevens for 5 minutes for your questions.
Great. Thank you, Madam Chair. Can you hear me okay? Excellent. Thank you.
We can hear you.
Phenomenal. It's great to be with you, and thank you for chairing this. Just very important and timely hearing, and thank you to our witnesses as well for your, not only for your testimony, but for your answers today to the questions. Specifically, as we were talking about how to build for safe communities and how to target populations who remain unvaccinated, I'm really focused on females, and in particular pregnant women who continue to have just some of the lowest vaccination rates in the country. Most recently reported somewhere between 25% to 30% being fully vaccinated. And a CDC analysis of data from the VSafe pregnancy registry assessed vaccination early in pregnancy and did not find an increased risk of miscarriage among nearly 2,500 pregnant women who received an mRNA COVID-19 vaccine before 20 weeks of pregnancy. The CDC announced this in August, and we continue, I know in Michigan, to try and communicate and reach out to young women, and most importantly, to save lives. And Dr. Wen, I know that you have been so very much on the front line of communication, particularly around combating vaccine misinformation and also reaching out to populations who we want to encourage them to get the vaccine. And I was wondering if you could shed some light around some of the effective strategies that public health educators have used or could use to debunk COVID-19 misinformation or even hesitancy, which is something that we've seen so pervasive among young women, unfortunately.
Representative Stevens, thank you for that excellent question. You're absolutely right. The rates of vaccination among pregnant women is extremely low, which is very concerning considering that pregnancy increases the vulnerability to severe outcomes from COVID-19. I think it does help to say that the American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, basically all these OBGYNs across the country have said that that these vaccines are safe and effective in pregnancy. Another strategy is to emphasize too that the protection also conveys to the baby that there are antibodies that are present that are then transferred through the placenta that then also are transferred through breast milk. Then we don't know how long that protection lasts, but that also is something that for new moms that may increase their likelihood of getting the vaccine as well. Ultimately, this is meeting people where they are, understanding what their specific concerns are about the vaccine, and also addressing the issue for expectant, not only for expectant moms, but women who are looking to become pregnant. One thing that I've also seen to be effective as a strategy is to say, look, we want you to be as healthy as possible in every way. We want to optimize if you have blood pressure issues or diabetes, we want you to be healthy in that way. And one thing that we can do that will help to protect you now as you're looking to start a family is to also get the COVID-19 vaccine. Debunking any of these myths of infertility are important too.
And Dr. Purnell, I know that your work has probably intersected with this as well, particularly as we have, another challenge, which is maternal mortality challenges in this country, and particularly as Congresswoman Lauren Underwood, who used to be with us on Education and Labor, is now on Appropriations, has formed the Black Maternal Mortality Caucus that many of us on this committee are a part of. And I'm just wondering if you've seen any research that shows how some of these challenges intersect with one another and how we can try and tackle both together.
Right. I would say that we have to tackle both together because what we should have learned through the experience of this pandemic is that equity always has to be a comprehensive approach. Black mothers are dying. Black persons who are pregnant are dying at disproportionate rates. Maternal mortality in this country as a whole is abysmal when you compare us to other developed nations. If we look at these in silos, we do a disservice to actually achieving health and well-being. The best thing we can do is to communicate to people in socially and culturally fluent terms. I do this day in and I do this day out. Whether it's a phone, it's a text, partnering with another group on a virtual, we have to have conversations where people are and then help navigate them along that journey. People want to hear from people who look like them. People want to hear from people who understand their stories. We know that's true. We can see with Black babies who fared better when cared for by Black physicians. So people want to know that their lives count and that their lives matter. And this pandemic is an opportunity for us in healthcare to perfect that because we've been failing at that miserably. That's why we got in the situation of mistrust, because of abuses and because of lack of meaningful engagement. So the more we can amplify the stories of those who have been vaccinated and who are pregnant, the more we can amplify the stories of those who have unfortunately had devastating outcomes because of COVID during pregnancy, the more I think we can help communities navigate these difficult challenges.
Phenomenal. We're so glad we captured that for the record. Thank you, Madam Chair, and we'll yield back.
Thank you so much. I now recognize Representative Leger Fernandez for 5 minutes for your questions.
Thank you so much, Chair Bonamici and Chair DeSaulnier. Thank you to our witnesses for your work protecting and advocating for the communities, exactly what we heard Dr. Purnell talk about in terms of they need to understand that we care about them and that we will work for them. I've heard today talk about the politicization of vaccinations and partisanship. I want to be really honest about where that politicization is coming from. Vaccines work across the country where they're being promoted. Where they're not working is where politicians, including my colleagues on the other side of the aisle, are arguing against the vaccine. In New Mexico, we lost 2 individuals who, taking their cue, sadly, from several of my Republican colleagues, to ivermectin, a horse dewormer. They took a horse dewormer, which certain of our Republican colleagues described as effective instead of the vaccine. This misinformation is killing Americans. I want every member of my community to live, whether they're in a red county or a blue city, in our villages. I want them to live and be healthy. I ask my colleagues on the other side of the aisle to stop sacrificing people's health and lives for political points. Our duty has to be about protection and care. Okay, so pushing against this information, I am proud that New Mexico has been a leader in vaccinations. More than 70% of New Mexicans aged 18 and older. Our Native communities in New Mexico and across the country were devastated because, as we just heard, there were issues that were underlined before COVID hit. I'm really pleased that in our Native, Latino, and rural communities, we're seeing an uptick, the 70%, 73%, we heard today, 73% of Hispanos have now received the vaccine. It surged. Dr. Martinez Bianchi, could you give us a description about what makes a program to vaccinate a Latino or other underserved communities successful?
Thank you, Congresswoman, for your. I think I need you to repeat the actual question.
So, we've seen this uptake, this surge with vaccinating Latinos. There was a recent study release that said we now have 73%. So what I want to hear a bit more about, and you wrote about those issues in your testimony, what makes, tell us about how we were able to achieve that and how we can use that as a model to continue and to serve these communities, such as Latinos and other underserved communities.
So creating a multi-stakeholder conversation. The media, Spanish, Latino media, has been one of our best allies in information, in accurate information of why the vaccines work, how to protect themselves, how to mask, why the masks work. They have been some of our best allies. Community health workers, representative of the Latina community, have been key at participating as promotoras, bringing the community forward and going into the community. And then us, members of the Latina community, as health professionals, engaging with both government, private, and other businesses. One great example, Vaccination of the Latino Community Credit Union. Often we don't talk about how much the private sector, that where people already are, or at comparative foods, or at restaurants. We have done vaccinations in taquerias, we have done them in supermercados, and we have done them at the Latino Credit Union. Going to the places that people already consider trustworthy and becoming, as a health system, a trusted member of that community that welcomes Latinos into our fold.
Thank you. And I wanted to go quickly to another point is we've had in my district, and I know this occurs all the time, where immigrant workers, healthcare workers, sometimes cannot get their U.S. Customs and Immigration permits renewed. And we know that immigrants play a big role in serving in our healthcare system. Could you talk about that impact that immigrants working in healthcare have with regards to serving not just immigrant communities, but our entire country, the role that, and that we need to sort of honor the role that immigrant healthcare workers play in our communities?
Well, I think it's important to note, as I mentioned before, the significant contributions of all immigrant communities to the economy and the country. The tremendous amount of support through taxes, both to state and federal government, which are written in my report. Wherever I am, wherever I have been as a Spanish-speaking rural doctor, city doctor, leader in academia, etc., I have found immigrants really doing a lot of work for their community, bringing the community together. And this is very, very visible right now in this COVID pandemic response. It is immigrants taking care of each other and also lifting the community up to be able to actually not just say we're here because we need, but we are here to support the rest of our community, including the US.
Thank you so much. I think we have to really remember that we cannot leave our immigrant communities behind today as we are looking at this, our larger legislation. Madam Chair, I yield back.
Thank you. And I now recognize Representative Mervan for 5 minutes for your question.
Thank you, Chairwoman. Dr. Purnell, what constraints or challenges affected COVID-19 vaccine equity in Greater Newark area earlier this year? And how can other cities leverage the best practices you have shared to drive down COVID-19 transmission rates for extended periods of time?
Definitely. I would say that the Newark story has not been different from many stories across America, and in particular in Black and Brown majority cities in urban America. The challenges that we initially faced were challenges rooted in access, meaning access was too often tied to a healthcare setting or institution initially. As the vaccine was made more federally qualified health centers, as the vaccine became mobile and on the move, meaning that there were community health workers in community with the state's mobile vaccination unit that was in Newark, East Orange, Irvington, Camden, Trenton, Bridgeton, you name it. People were able to get their vaccine as close as possible to where they lived, and people were able to get the vaccine from trustworthy community assets. I want to emphasize that word asset. Too much of healthcare and public health is from a deficit approach. When there are barriers or gaps and inequities, we must find assets in community and then partner and share power with those assets. So in addition to assets that could help convey value and trust around language or literacy, there were assets that could make the vaccine more accessible by convenience or time. So we're really employing this idea of a prevention army. And we're looking not just to bring vaccines to the front lines of where people are, but care to the front lines of where people are. Getting community health nurses, public health nurses, getting community health workers, getting those folks as close to where people are. That's the Newark story. And that's why Newark has gotten to where it is currently. Is there more work to be done? You better believe it. But the Newark story is one of, I want to say, of success and one of overcoming. And the more that we can help empower communities to decide, and more that we can help empower communities to say, this is the way that the approach is going to be most effective here, the better. And the last thing that I would say is our hospital was an example of an institution sharing power, whether it was the city health department directly supplying vaccines, or whether it was FEMA. We had our EMS staffing over 500 events and sites to be as a support. That's how you achieve an equitable response.
And I thank you very much, Dr. Purnell. I'm from Northwest Indiana. I represent Gary, Indiana, Hammond, Indiana, East Chicago, Indiana. And all of those federally qualified health centers were boots on the ground. And you're exactly right. They are assets that were meeting people where they are. And we had our share of success had a lot to do with not only the combination of the health departments, along with the federally qualified health centers and the faith-based community to push and to have those initiatives and assurances to the constituencies that there's value in it. So I thank you very much. My next question is for Dr. Wren. Direct care workers and agencies receiving Medicaid funding are among the 17 million healthcare workers who must now be vaccinated, according to the new federal mandate. How could vaccine hesitancy among this critical workforce impact the people that rely on them for home and health and community-based services, which are largely funded by Medicaid?
Thank you for that question. I have stated earlier that I am a big proponent of vaccine requirements. It is something that we know dramatically increases vaccination numbers, and we have already seen this happen. Houston Methodist, for example, one of the first hospitals, out of 25,000 workers, only about 150 did not comply with this mandate. We also know that when people are unvaccinated, of course, they're exposing their vulnerable patients and nursing home residents and individuals that they're caring for in the home care setting. Also, it increases increases their likelihood of being out of work if they are quarantined, if they're exposed to somebody who is positive for COVID-19. And so I recognize the challenges that may be faced by organizations that may have staffing shortage issues, but we also have to recognize that there's another side of this, that it also increases the protection, including for some of our most vulnerable individuals. Finally, a lot of employers have actually been looking for cover, and the federal government saying that there is a vaccine mandate provides them with the cover that they need in order to implement vaccine mandates that many of their employers and certainly the people that they serve have wanted.
I thank you, Dr. Wren. I want to thank all the participants who have testified today with your passionate views, and may we always keep advocating for the health of our nation.
Thank you, Representative. I now recognize Representative Bowman for 5 minutes for your questions.
Thank you very much, Madam Chair. This question is for Dr. Martinez Bianchi. I want to thank you so much for joining us today and for providing us with such important information on the disparate impacts of COVID-19 on Latinx communities. It is clear from your testimony that uplifting the voices, experiences, and needs of the communities most impacted by health inequity is the first step to pursuing justice. This is something that my office and organizations in my district have been working to do as well since the onset of the pandemic. In the 16th District of New York, nearly 2/3 of constituents are Black or Latino. White households in my district make double what Black and Latinx households make, and these income disparities are inextricably linked to disparities in health outcomes, as we all know. Earlier this year, my office helped advocate for vaccine sites to be located in Yonkers and Co-op City, 2 areas with high concentrations of Latinx and Black residents. Before these sites opened closer to home, residents would often have to spend 2 hours on multiple trains and a bus to reach the nearest vaccination site. Continuing to address these barriers to equitable health access is vitally important for my constituents. Reflecting on the stories that you have heard thus far in your community, what do you think are the biggest barriers to vaccine access that are faced by Latinx communities who still have not gotten their vaccine or are now eligible for a booster? And what do you think are the most important strategies that organizations and community members can employ to combat those barriers?
So thank you, Representative Bauman, for such a great question. And the story that you are talking about in New York is very similar to what we've seen initially also. A lot of the vaccination, a lot of the testing initially was set alongside normal places where healthcare is delivered. And what we know is that we're not delivering it where the people are. So best approach is going to where the people are, listening to the community, understanding what their fears, their concerns, and explaining that one of the things that I heard a lot from both African American and Black and Latino communities was, why now? Why are you now talking to us, telling us we need to get vaccinated when we were completely forgotten before? And what I said was, now, because the majority of white people have gotten vaccinated, because the people who had the access and had the privilege and wanted the vaccine already got it. So now we're coming to talk to you because maybe there is an important part of this information that you're not aware of. And I've been in many places. I have sat at lunchtimes when we have done vaccination events in so many different settings, and it was sitting down with people at their table and saying, hey, who's vaccinated here? Asking one-on-one, what is it? What are their concerns? And then suddenly realizing that a group of 7 people will get off of their table and go get a vaccine. Is going one-to-one, is having people that speak the language, that look like you, that look like me, that are going in and answering the questions, being about that humility that we're talking about, but being about that engagement. And then setting the settings where people are, getting those vaccines where people are, provided by people, again, that look like you, look like me, who are speaking the languages of everyone that we're trying to reach out and to get vaccinated, working with schools.
No, absolutely. And you're referring to the lack of trust that's been in place in Black and Latino communities for several decades throughout American history. And that trust needs to be rebuilt with intimate engagement and building relationships. Thank you so much. Dr. Wen, I have a question for you. First of all, thank you again for taking the time to be here and providing your expertise. Listening to your testimony, you mentioned recent data that nearly half of the unvaccinated are not opposed to getting the vaccine. The key, as you say, is community outreach, as we just heard. As a former teacher and principal, I also know that schools can play a vital role in this type of community outreach by helping to identify community needs, provide services directly to students and families, and connect community members to external resources when unable to directly provide them. You mentioned briefly that schools and transportation hubs could be additional access points to vaccines. Can you talk a bit more about how schools can play a role in helping to test and vaccinate key populations, such as the unvaccinated but willing, those who are now eligible for boosters, and young students who are or may soon be eligible for vaccines? And how can we coordinate across agencies and levels of government to support schools in playing this role?
Thank you, Representative Bowman. I completely agree with you. I used to oversee school health for the city of Baltimore, and I definitely believe that schools are a hub. Ideally, they're not just the hub of healthcare for the student, but also for the entire family. And so when we get vaccines approved for younger children, but also now vaccines are approved for 12 and older, if we should be able to offer the vaccines in schools, but also offer parents and their extended family the opportunity to get vaccinated there as well. And I certainly think we should do a lot more to expand testing in our schools. Ideally, there's rapid testing available to every student every week, the way that Ella Unified, for example, has done, some others have done, and perhaps those tests could be made available to the entire family too.
Thank you so much, Madam Chair. I yield back, and sorry for going over my time.
No worries. Thank you, Representative. I see no further members to ask questions, so I want to remind my colleagues that pursuant to committee practice, materials for submission to the hearing record must be submitted to the committee clerk within 14 days following the last day of the hearing, so by close of business on October 11th, preferably in Microsoft Word format. The materials submitted must address the subject matter of the hearing. Only a member of the joint subcommittee or an invited witness may submit materials for inclusion in the hearing record. Documents are limited to 50 pages each. Documents longer than 50 pages will be incorporated into the record via an internet link that you must provide to the committee clerk within the required time frame, but please recognize that in the future, the link may no longer work. Pursuant to House rules and regulations, items for the record should be submitted to the clerk electronically by emailing submissions to ednlabor.hearings@mail.house.gov. Again, I want to thank the witnesses for their participation today. Members of the Joint Subcommittee may have some additional questions for you, and we ask the witnesses to please respond to those questions in writing. The hearing record will be held open for 14 days to receive those responses. And I remind my colleagues that pursuant to committee practice, witness questions for the hearing record must be submitted to the majority committee, staff, or committee clerk within 7 days, and the questions submitted must address the subject matter of the hearing. So I now want to recognize a distinguished ranking member of the Health Subcommittee, Ranking Member Allen, for a closing statement.
Thank you, Madam Chairman. And I want to thank the witnesses. This has been a very informative hearing. I think we've learned a great deal about where we are and maybe where we need to go. As we discussed today, Operation Warp Speed was the gold standard of vaccine development and distribution. I don't think there's any argument about that. Under the Trump administration, our private healthcare sector was able to produce several life-saving vaccines in record time. This proved yet again that America's healthcare system thrives when government gets out of the way and supports private innovation. As we continue discussing successful models for protecting communities from COVID-19, we must acknowledge that the most effective mitigation and prevention strategy, vaccination, is both free and widely available for every American over the age of 12. Our free enterprise system and the private healthcare industry made this miraculous feat possible. Additionally, our nation's pre-pandemic economy was booming, and I want to give a shout out to all of our medical personnel for their great work during this very difficult time in our economy. Again, I said the pre-pandemic economy was booming. Contrary to a claim made earlier in this hearing, economic growth during the Obama economy suffered greatly because of top-down government regulations and a hostility toward job creators. Under President Trump, unemployment, particularly for minority groups, was at an all-time low, worker wages skyrocketed and job creation boomed because of the Trump administration deregulatory policies. Business owners and workers are eager to get back to this unprecedented period of economic growth and prosperity. But it seems that President Biden appears to know little about creating a booming economy. With 3 COVID-19 vaccines approved by the FDA, our economy should be back to normal. There are currently over 8.4 million unemployed Americans and 10.9 million job openings, a gap that is due in part to the Biden administration's absurd policies that are keeping would-be workers out of the workforce. For minority groups, the unemployment rate is a staggering high 8.8%. It is truly astounding to watch an administration trade long-term economic prosperity for short-term liberal special interest. The worst part is there is little evidence that the government-mandated lockdowns did much to reduce COVID-19 transmission. To build on these early successes, it is imperative that we reestablish local and state control, working together with those leaders to execute policies that encourage vaccination. More top-down mandates from Washington will not alleviate the financial suffering this president's policies have inflicted. Again, I thank the witnesses for participating today, and with that, I yield back.
Thank you, Ranking Member Allen, and I now recognize the distinguished chair of the Health Subcommittee, Chairman DeSaulnier, for a closing statement.
Thank you so much, Chair Bonamici. I really appreciate it. Ranking Member Sparks and Ranking Member Allen, thank you. And I want to especially thank all of our witnesses. Your testimony was terrific. As I shared at the beginning of the hearing, those who have been historically and now continue to be left behind by our healthcare system have suffered the greatest losses during this pandemic. The Delta variant is only deepening those inequalities. Today, we heard how communities across the country are leading effective vaccination initiatives to fight back and protect our loved ones from COVID-19. We still have a long way to go, and unfortunately, the most vulnerable Americans are some of the last to get vaccinated. To that end, we must rally behind compassionate, community-based initiatives that are reaching every corner of America and are doing something very important for everyone during this historic pandemic. Thank you again to our witnesses. I now want to recognize the distinguished, I already did. I want to turn it back to you, Madam Chair. Thank you.
Thank you, Chair DeSaulnier. And it's my understanding Ranking Member Sparks is no longer on the platform, so I'll recognize myself for purpose of making a closing statement. Thank you so much to the witnesses for sharing your expertise and your experience. And today we reflected on the importance of equitable access to the COVID-19 vaccine in our efforts to defeat dangerous variants and protect our loved ones. As of this morning, 56% of Americans are fully vaccinated. This is a testament to the successful vaccine initiatives made possible by community leaders and the historic funding provided through the American Rescue Plan. But unfortunately, as our witnesses made clear, there are still many Americans not getting the vaccinations they need to stay safe and healthy. And as a result, we're experiencing a resurgence of COVID-19, and too many Americans, primarily those who are unvaccinated, are losing their lives. And throughout this hearing today, I've been thinking about the challenges and the opportunities, both of which we've discussed today. And I'm following up on Representative Ledger Fernandez's story. I had a conversation with the school superintendent in the district I'm honored to represent in a rural area where even though there's a vaccine mandate, many of the teachers are not getting vaccinated. And she said to me, my parents are calling and saying, I don't want my child who's too young to be vaccinated in a classroom with a teacher who's not vaccinated. What am I supposed to do? And today's hearing will help us answer that question. Oh, and then she added, and by the way, I can't get to worming medicine for my horse because it's all sold out. So challenges, yes, we have, but we also have the opportunities. And following up on Mr. Mervin's comment about the importance of our FQHCs, our federally qualified health centers. In the district I represent, we have a wonderful Virginia Garcia Memorial Health Center. And they have done a remarkable job with their mobile health clinic, going out to the farms and fields and making sure that the people who are working there, harvesting our crops and getting food to market, are vaccinated. So lots of opportunities. And just over the weekend, About 400,000 Americans got booster shots at their local pharmacies. So we're making progress, but we know that communities must continue to invest in these vaccination initiatives and make sure that every American has equitable access to a vaccination. And if you haven't received yours yet, go to vaccines.gov to learn more and find a provider near you. It's the best thing you can do